Can everybody hear? I apologize for the technical glitch that has happened. Hello.
We can hear you, Samir.
Yes, Samir.
There was some technical glitch and there was a network problem from Jenika's side. They have messaged that there is some technical glitch. They are trying to rectify it. Is Madam Tasneem Madam still online with us? Tasneem Madam?
Samir, Tasneem Madam has not yet joined back, I think. We are waiting for her.
Dr. Tej, have you contacted Dr. Tasneem Madam?
Yeah, I called her twice. She disconnected the phone, so maybe she's trying to log in.
Hello.
Yes, Samir, we can hear you.
Yeah. Has Tasneem Madam joined back?
I don't think so.
Okay, I'll ask Rajesh to call her up.
Anybody can call actually.
I tried again. Madam का phone busy है.
Dr. Tej, can you just ring up Dr. Tasneem again?
Ma'am, I just tried her third time. It was coming busy. I think either
Hello,
she's talking
Tasneem
to...
Madam is joining back again.
Yeah.
And she'll start from the beginning.
Yes, sir.
Hello.
Hello, Rao, sir.
Hello. Hello.
Rao, sir, we are able to hear you.
Can we start next speaker? Tasmir ma'am.
जॉईन झाल्या का तस्नीम मॅडम?
Hello.
शिल्पा मॅम,
हा बोला ना वर्षा मॅडम.
आपण नेक्स्ट स्पीकरला करू शकतो का? नंतर तस्मीर मॅम आल्या की या स्पीकर नंतर त्यांचं घेऊ आपण, काही प्रॉब्लेम नाही.
प्लॅटफॉर्म लिमिटेड वेळेचे आहे का?
नाही, म्हणजे कसं आता लाईव्ह स्ट्रीमिंग चालू आहे तर सगळे आहेत तिकडे युट्यूबला वगैरे ना, तर मग
Tasneem madam has joined. Just hold on, please.
या जस्ट वेट. 2 मिनिटं द्या आम्हाला वर्षा मॅडम.
यस सर.
Yeah, welcome back, Tasneem madam. We're able to see
Okay.
you.
Tell me what happened. I have zero clue because I could only see my screen.
Madam, sorry, glitch from the Jenica side.
This meeting is being recorded.
It just got disconnected.
Okay,
Started.
not a problem.
Ma'am, can you please start again from the beginning?
Yeah, madam.
Yes, I will.
Thank you.
Thank you, madam.
Thank you for the patience.
Just a minute, huh?
You are on mute, madam. Unmute yourself. Tasneem madam, unmute yourself.
Yes. Okay. We're good and ready to go. Sorry, I'm using my daughter's laptop, so I was a little lost. Okay, can you see it now?
Yes, madam.
Yes, ma'am.
Okay.
Good.
So Rajesh called me and asked me to do this topic, to hold or to bleed. And we wanted to discuss the perioperative use of anticoagulants and antiplatelets. So this kind of completely brings us to the ASTRA guidelines. We need to know that, every couple of years, these guidelines keep changing depending on the new drugs that are coming out. And of course, what data has been collected over the last 8 years or 10 years. So the last guidelines came out, that was the 4th edition that came out in April in 2018. And that was the next edition that came out after 2010. So the latest guidelines that we have currently is 2018 guidelines, which we are following currently. So basically, it is about knowing, when we see a preoperative patients, it's about figuring out whether we want to perform a neuroaxial block on these patients who are receiving this perioperative anticoagulation. And of course, this has to be made on a very individual basis, weighing the risks of spinal hematoma versus the risks of regional anesthesia for that particular patient. So since, heparin is the gold standard, which has been used when we were residents, all we had was heparin. So I thought we'll just revise what we have about heparin. Very few people now use unfractionated heparin. Everybody has moved on to other drugs and to low molecular weight heparin. But just for a recap, that when we are using heparin, we always wait for about 4 to 6 hours. We need to understand that the half-life is 1 to 1.5 hour of heparin, and we need to wait for 4 half-life before we can do any procedure. We need to hold the medication for about 4 half-lives. So if your patient is on IV heparin, we need to wait for about 4 to 6 hours before we do any neuroaxial blockade. It is ideal that we hold the medication again for 4 to 6 hours before catheter removal, and we do not restart heparin for about 1 hour after catheter removal. And at all points of time, frequent neuro checks are done during when the catheter is inside, as well as when the catheter has been removed, even after that, to keep doing frequent neuro checks. Okay, so this forms the basis of everything and all the anticoagulation perioperatively. Whatever drug that you're using is performing frequent neuro checks while the catheter is inside, and of course, even after the catheter has been removed for a period of time. So I thought, once we're going through this, let's just go through some common things that we come across during our pre-anesthetic checks, and whether to give neuroaxial blockade or not to these patients is something that we will keep discussing, and we'll go through the ASTRA guidelines as we are doing this. So assuming that you have a 36-year-old female patient who's primi gravida with PIH, with a precious pregnancy, and because of her PIH, she has been started on low molecular weight heparin. Usually about once a day they receive these, and this patient has been posted for an elective LSCS. So let us see what the guidelines tell us here. So when you're looking at low molecular weight heparin, we are also looking at whether it's a once a day dose, either whether it's a therapeutic dose or it's a prophylactic dose. Now this patient is probably receiving a prophylactic dose, so she could be on a dose which is once a day. Okay, so over here you're going to hold, before you do any neuroaxial blockade, you're going to make sure that at least 12 hours prior you're going to hold this medication. You're going to restart the medication in case it is required after 12 hours of the procedure. Before catheter removal, if this patient has received a catheter, if the patient has received a once a day dose, the catheter should be removed before initiating low molecular weight heparin in the postoperative period. And after catheter removal, you will wait for up to 4 hours before you actually give the postoperative dose, and at least 24 hours after the neuroaxial procedure. The half-life of low molecular weight heparins, of at least enoxaparin and dalteparin, that is fragment, is about 4 to 7 hours. So that's the reason why we need to wait for at least 3.5, 4 half-lives before we need to hold the medication before doing any procedure. So now, assuming we have a 58-year-old patient who has rheumatic heart disease, has undergone a mitral valve surgery about 11 years ago, and is receiving warfarin 2 milligrams daily, and has been posted for an unobstructed, that means nearly an elective umbilical hernia, and when the patient saw you, the INR was 2.3. So what do the guidelines tell us for warfarin? So when you're looking at warfarin, we need to understand that we need to hold the medication for about 5 hours. We need to have the INR less than or equal to 1.2. So if the first dose has been given prior to surgery, you wait for 24 hours and then check the INR. To restart the medication, you can restart it immediately because it takes time for warfarin to start acting. Before catheter removal, you make sure that the INR is less than 1.5 before you remove the catheters. You maintain the INR between 1.5 and 3 to make sure, and you also check for frequent neuro monitoring in between while the catheter is inside. If the INR is more than 3, you will hold warfarin and keep the catheter in place. You will remove the catheter only when the INR reduces to less than 1.3. To restart medication after catheter removal, again, there's no need to delay it because the onset of action of warfarin is prolonged, and neuro checks for at least 24 hours. And in case there is any problem, there is a reversal available with vitamin K and with FFPs for warfarin. Okay, the half-life of warfarin is 20 to 60 hours, and that's the reason why we need to stop it for about 5 days. So now suppose you have a 45-year-old female coming to you with no comorbidities, but had history of COVID about 3 months back with ICU admission and high dose, and had received high dose steroids. And because of that, the patient has now been started on tablet Xarelto, oral 10 milligram HS, posted, and she has been posted for a total hip replacement because she had been on high dose steroids. Now we need to understand that all these factor 10A inhibitors require a very long period of withholding the medication before you actually do a neuroaction blockade. So Xarelto is a very commonly used drug now, and so is Eliquis. Both of them are available, and they're used quite commonly along with Arixtra. Now, unfortunately, with fondaparinux, we do not have enough of data to tell us what to actually do. So Astra has given that there's no recommendation being given yet whether to use it with Arixtra or not to do any neuroaxial blockade while Arixtra is going on. The half-life is very, very long, about 17 to 21 hours. So we still don't have data about when to actually do a neuroaxial block in the presence of Arixtra. It's totally to be avoided epidural catheters to be kept in place while Arixtra is going on because there is no data yet to tell us what needs to be done. After catheter removal, maybe in 6 hours, you can start the first dose of Arixtra, and you need to withhold it for a very long time. And especially in patients with any renal impairment, all the factor 10A inhibitors are going to get even further prolonged. So ensure that your creatinine clearance is normal when you're using these. In case of patients who are having a high, are either in CRF or having a higher creatinine value, then you will have to probably wait for a longer period of time when these patients are receiving factor 10A inhibitors, that is either rivaroxaban, Xarelto, apixaban, that is Eliquis, and of course Arixtra if it is fondaparinux. Most of the others require at least to withhold medications for 72 hours before the procedure. That means 3 days prior to the procedure, we need to withhold this if you're going to give a spinal or an epidural. Postoperatively, and avoid while the catheter is in place. So at least tell your surgeons to not start Xarelto, Eliquis while the catheter is in place. After removal of the catheter, also it is recommended that you wait for at least a minimum of 24 hours before you restart your Xarelto and Eliquis. In case of any bloody tap, okay, discuss with the person who's doing the surgery and discuss with the surgeon about any chance of any motor loss while, if case there has been a bloody tap while putting the catheter, while having a spinal, or while you are inserting or removing your epidural catheter. And like I said, all of them are going to be affected because of your renal problems. So let's get on to the next one. Suppose you have a 58-year-old morbidly obese patient with a recent history of pulmonary embolism post-DVT. And this patient has been started on tablet dabigatran 150 milligram once at night. And this patient has come in for a total knee replacement. How will you take this further? So when you're talking about dabigatran, this is it's again popularly with all the orthopods, they're all using these drugs in the perioperative period. Here also, if you look at the half-lives of dabigatran, it's about 8 to 17 hours. Okay, these other two drugs are not available in India at all. And of course, there is no data available currently with these drugs. Of course, the next guidelines might have something else completely in store for us. So when you're looking at dabigatran, you need to withhold the medication for 5 days prior. Okay. And of course, if the creatinine clearance is good, then maybe for lesser period. And if the creatinine clearance is worse, then you need to keep it for even longer, that you need to, stop the drug for withhold this drug before doing any neuroaxial blockade. If you're looking for any chronic pain therapies in a patient who's receiving dabigatran, 4 days you need to stop it, and 5 to 6 days if there is any renal impairment. Totally not recommended to use it while your epidural is in situ. So epidurals are completely out with these direct thrombin inhibitors as well. Or it's more like there's no data available about what is going to happen. And that's the reason why the ASTRA guidelines in 2018 do not recommend using it with epidurals in place. You need to hold medication after catheter removal for about 34 to 36 hours. That means at least for 1.5 days after your catheter has been, the epidural catheter has been removed. And you can restart the medication after catheter removal for about 6 hours. Okay, and if you have a traumatic puncture, then you wait for at least 24 hours after the traumatic puncture to restart your medication. Similarly, here again, longer hold times in patients with renal impairment. Okay, so make sure that you are able to, the renal status of these patients who are receiving direct thrombin inhibitors before you start using them. And you ask your orthopods to, consider waiting for adequate amount of time before you restart these drugs. Now, assuming you have a 76-year-old known case of hypertension, diabetes mellitus, ischemic heart disease status, post-cardiac bypass, which was done in December 2021. Now, currently that patient is on tablet Brilinta 90 milligram HS, and the patient comes with an complaints of acute onset of abdominal pain. On diagnosis, it is an obstructed inguinal hernia, which is coming up for an emergency surgery. Then what will you do? So when we look at all the antiplatelet drugs, we look at Brilinta, that is ticagrelor. Again, you need to understand for aspirin that there are no restrictions anymore. Of course, when we are talking about aspirin, we're talking about 75 milligrams of aspirin. We're not talking about 150 milligrams or 300 milligrams, which, some of our patients continue to take without realizing which aspirin that they are actually taking. Okay, so ensure that it is 75 milligrams of aspirin, and then there are no restrictions for any of your neuroaxial blockade. If your patient is on clopidogrel, you wait for 5 to 7 days. Restart medication immediately if no loading doses are given. You hold the medication after catheter removal for 1 to 2 days, and you restart medication after catheter removal at 0 hours. With ticagrelor, that is Brilinta, which is again orally available, and lots of patients are receiving this antiplatelet drug, we need to hold medication for about 5 to 7 days. So if you look at, antiplatelets, we're looking at 5 to 7 days. That's because the half-life of the life of your platelet is that amount. So new platelets will come into circulation in about a week's time, and that, changes your entire coag profile, the function of the platelets. And that's the reason why we're looking at 7 days for antiplatelet drugs. So with Brilinta, it is immediately, if no loading dose, avoid while catheter is in place again. You see over there, you hold medications before catheter removals. Ideally, after 5 to 7 days, you may place a catheter. all right? But ensure that before the catheter is removed, that you again will wait for 5 to 7 days. So no ticagrelor while your epidural catheter is in situ in these patients, absolutely. Then we come to our entire dose of fibrinolytics, that is streptokinase, alteplase, all these drugs which are given. There is no way that you're going to be giving any regional anesthetics, mostly neuroaxial blockade, to any of these patients. Okay, so because all these patients are going to receive these drugs only if there is going to be any other cardiac issue. That's when these patients are going to be thrombolized and receive fibrinolytics. Now, it is possible that you need to give streptokinase while the catheter is in place, epidural catheter. So ensure that there is no epidural catheter in place by the time streptokinase is given. And then the last group of drugs that we have are, of course, the glycoprotein 2B and the 3A inhibitors. These are all injectable drugs which are used in the cath labs. They give them. Tirofiban is used quite commonly for patients who are unstable with arrhythmias, patients who are having atrial fibrillation. These patients are put on these drugs to prevent clot formation in the left atrium. So it is recommended that before you give any neuroaxial blockade, you wait for 4 to 8 hours. And of course, no epidurals while this drug is being used. So these are the 2018 updates, which have been based on the ASRA guidelines, which have been published before. So what I feel that, these drugs, most of these, 2018, they also came up with the anesthetic management of patients undergoing plexus and peripheral blocks. What they recommended is for patients undergoing pre-neuroaxial, deep plexus or deep peripheral blocks, we recommend that the guidelines regarding neuroaxial techniques be similarly applied. So technically, any place where you will not be able to give pressure. So the guidelines will be different for probably, if you're looking at a axillary block versus a supraclavicular block. If you're looking at a supraclavicular block, then you have to understand that it is a deeper plexus block. It's a deep peripheral block. So the guidelines will be same regarding that as similar to the neuroaxial techniques. Now, for patients undergoing other plexus or peripheral techniques, we suggest management, performance, catheter maintenance, and removal based on site compressibility, vascularity, and the consequences of bleeding in case they occur. So, if you can give pressure at that vessel around which that you're giving your neurovascular block, you can probably go ahead with it, but it will again be done on case-to-case basis. But of course, the deep plexus blocks should be avoided and should be treated with the same guidelines as the neuroaxial techniques are. We also need to understand that commonly used dietary supplements have coagulation, where they have this thing on the coagulation function during surgery. And things like similar, things like fish oils, melatonin, ginseng, a lot of Chinese medications now add ginseng. A lot of patients, please keep taking these supplements as they're growing older. They keep taking these supplements, and you have patients taking supplements for about a month or two, taking a lot of supplements, ginger, garlic, all kinds of things patients are receiving now. So what we need to do is, in case you are having any patient in the perioperative period who is taking any of these supplements which are known to cause, thinning, blood thinners, then you need to ask them to stop all these supplements at least for a week prior to, your surgical procedure and prior to your neuroaxial blockade. If the young ASA grade 1 patients, you need not worry, but in case they are already on some other anticoagulants or antiplatelet drugs, you make sure that these supplements are all stopped at least a week prior. So I wanted to share one of our case reports that we, had, which we got published in the Indian Journal of Critical Care Medicine. So we had an epidural hematoma, and what we wanted to highlight is the vigilance which needs to go beyond guidelines. So if you can see over here, we had a patient who was 46-year-old for a CA ovary. We had put in a thoracic epidural, T78 level. Patient was in the post-operative period in the ICU. The epidural catheter was removed, and then fragment was given to this patient after about 6 hours of catheter removal. Now, about 5 to 6 hours after the fragment was given to the patient typically had complete loss of motor power. And she said, I'm feeling like a band around my chest and I cannot feel the lower half of my body. So immediately within about 2 hours, this patient was taken for an MRI. As soon as a high index of suspicion was done, and patient was taken for an MRI, and you can see this clot over here. In about 2.5 or 3 hours, patient was on the table, and you can see the patient was decompressed. You can see the hematoma which is visible on decompression, and this is after the hematoma had been evacuated. It took the patient about 7 or 10 days to start getting motor action back. By the time the patient was discharged, about after 3 weeks, she had about grade 3 power, and in about a couple of months, the patient was having normal power. That's only because we were able to pick it up very, very early. Within 3 hours, the patient was on the table and was being decompressed. And of course, this is also completely after following all the guidelines. This article was published in 2018. So the guidelines that we were following were the 2010 guidelines. So what was the 2010 guidelines? Previously recommended was 10 to 12 hours for both needle and catheter placement and catheter removal. And subsequently, low molecular weight heparin 2 hours after catheter removal. These recommendations incorporate the labeling changes made by the FDA. So this was what the previous guidelines was telling us. You can subsequently give low molecular weight heparin 2 hours after catheter removal. This was 2010 guidelines. Now the 2018 guidelines, we recommend the first dose of low molecular weight heparin should not be administered more than 12 hours after needle or catheter placement. And the second or the post-operative dose should occur more than 24 hours after the first dose. Indwelling catheters don't represent increased risk and may be maintained. No additional hemostasis altering drugs be administered because of additive effects. Catheter removed 12 hours of the last dose of low molecular weight heparin, and subsequent low molecular weight heparin more than 4 hours after catheter removal. So 2018 has increased the subsequent dose of low molecular weight heparin. Initially it was 2 hours, now it has been increased to more than 4 hours after catheter removal. So what we need to highlight here is to be absolutely vigilant. So maybe the next guidelines that come will have a completely different set of hours that you require for every drug as more and more data is gathered. So like we all say that the eyes can only see what the mind knows. It's technically impossible for us to keep all these guidelines in your mind at all points of time, especially if they're changing over years. Right? So the next set of guidelines should be out soon. It's already from 2018. It's already 2003. So in the next couple of years, we'll have another set of guidelines. So the most important take-home message that we need to understand is display the latest guidelines in your OT or in your OR, which is visible to everybody so that everyone is aware of what the latest guidelines tell you about new drugs, There are more and more drugs being added to the armamentarium, and it's technically or physically not possible to remember so many all the time. Be abreast with the latest guidelines. Like I said, newer drugs are constantly being added, and eternal vigilance even beyond guidelines. So like this patient, we had done whatever the patient that I described. We had followed guidelines which were there on paper at that point of time, but in spite of that, we had a high index of suspicion, and it's ideal to maintain a high index of suspicion in case of complications. So thank you so much for a patient hearing. If there are
Thank
any
you,
other
Tasneem, madam.
we can take them.
Madam, thank you so much for a nice talk on antiplatelet and anticoagulants. I request all the participants not to just post their MNC registration numbers in the chat box, but they should be posting the questions. It should be an interactive webinar, throwing questions at the speakers to get the answers out from them. So I would request everybody to post their questions in the chat box. Now I would request Dr. Shilpa, Dr. Garu to check the chat box for any questions to be asked to madam. We'll take for 3 to 5 minutes and then we'll proceed to the next topic.
Over to Dr. Garud. Dr. Garud, sir, for chat box questions. And Dr. Samir, your voice was echoing. Whether you are logged in from two devices.
Yeah, voice is echoing. Even Shilpa, your voice is echoing.
Every voice is echoing only, ma'am.
आता बरोबर येतोय.
Okay.
Okay.
Any questions to be asked?
There was one chat box question. I was waiting for Dr. Garud to take it.
Yeah. There is one question I can see. That one patient is for hernia surgery, CABG done 6 months ago on dual antiplatelets. Should we be using bridging therapy for all patients?
It depends on how long your stent has been put in.
If it is 6 months,
Right.
now we are getting patients who have been operated 3 months ago or 6 months ago and coming for surgery, and the surgeon wants to
bridging,
operate. They said
definitely.
everybody is doing it. Why not me? I want to go ahead with the surgery. So then it is up to us whether they don't want a clopidogrel to be on for the surgery. They don't mind aspirin to be on, but they don't want clopidogrel. So just CABG or a PTCA done 3 months or 6 months ago, even though we ask them to wait, the surgeon doesn't want to wait nowadays.
So ideal guidelines tell you that you're not supposed to, if it's a drug-eluting stent, you're not supposed to stop dual antiplatelets for at least a year.
No, nowadays many of the cardiologists, they advise even for after 6 months you can stop the clopidogrel and put them on Clexane. That's what they are advising. Whether it is the correct thing to do or they are doing something wrong.
You can bridge them for the surgical period. You can bridge them with low molecular heparin, but do not stop completely any antiplatelet or
no, aspirin and low molecular weight heparin.
Aspirin and low molecular weight heparin you can continue. So
and
if you
low molecular heparin, one OD dose or BD dose?
You will take a BD dose. Bridging will have a BD dose.
BD dosing.
Yes, BD dosing, bridging in consultation with your cardiologist.
And then hold LMWH for 24 hours before the procedure.
For 12 hours before surgery.
12 hours.
No, for BD dosing, they advise for holding for 24 hours.
But Dr. Samir, it is recent CABG or recent stent, right? So it is 12 hours. That's what I feel. Yes, Tasneem, madam.
So ideally, you should counsel this patient that he should wait for, the idea of a stent stenosis is very, very high within the first 3 or 6 months. And that's the reason why you don't want to stop your dual antiplatelets. So I think you should speak to the surgeon and counsel the patient and the surgeon that it's not such an emergency unless it's an obstructed hernia or it's an irreducible hernia. So if it's an elective hernia, it's wiser to wait for another couple of months, bridge the patient, and then take the patient up for surgery.
This brings me to one topic where we are discussing heparin also. A lot of patients are on dialysis nowadays, twice a week, thrice a week. These people require surgery. And then we write heparin-free dialysis. Okay. In that case, what is the guideline for a neuraxial blockade or epidural insertion?
So during dialysis, if it's heparin free, it's heparin free. There's nothing that you need to really do for those patients.
Right.
But if the patient has received a heparinized dialysis, then this is unfractionated heparin. So 4 half-lives, 4 to 6 hours before a neuroaxial blockade is all
Okay.
that you need to do.
Yeah. And
So-
another question is, like Samir said, cardiologists, whenever we have a very high risk patient, frank ischemic changes and blockages, but he comes for a emergency surgery, the cardiologist always advise go ahead with the surgery with the risk and to be considered for PTCA after the surgery. So in this scenario, what should be our stand?
So if PTCA afterwards, now in this patient, you wouldn't even consider a neuroaxial blockade. So what drugs the patient is taking, technically, to you as an anesthesiologist, it doesn't really matter. Okay, so if it's an emergency surgery and the patient is on clopidogrel, you probably will arrange for, single donor platelets or adequate platelets before you take the patient up. In case there is a surgical bleed, you will infuse platelets or perioperatively give platelets to these patients before the major surgical procedure. But if your patient is unstable, I don't think you would even consider a neuroaxial blockade in these patients. So what the patient is receiving, any of the anticoagulants, antiplatelets, should be taken along with what kind of surgery is going to be there. If it's an emergency surgery and you don't have enough of time, the number of hours that you require for this, to stop these drugs, then you go ahead with a general anesthetic. You don't even consider a neuroaxial blockade. Like you'll have lots of old patients coming with fracture neck femurs. Most of the orthopedic guidelines now do not recommend waiting for those number of days. Wait for 3 days, wait for 5 days. Keeping these patients on on bed with a fracture is worse for the lung status, worse for the DVT.
Yeah.
So most of the times, go ahead with a general anesthetic. Use antiplatelets. Use platelet transfusion in case of extra bleeding, extra surgical bleeding in case there is, if these patients are on clopidogrel. So we kind of take the patients as early as possible within the first 48 hours. In case the patient is even on clopidogrel, wouldn't consider giving a neuroaxial blockade, would go ahead with a general anesthetic and manage the surgical bleeding as and how it happens. So there is another phenomena known as a rebalanced hemostasis. Okay, so where it was especially described for liver, for patients who are having altered INR, having an altered INR but not bleeding so much technically during surgical this thing. So a similar kind of a thing probably applies to the rest of the coagulation cascade as well, where if you're using clopidogrel and the platelets are not functioning, maybe the other factors are kind of holding up, because even with patients with clopidogrel, you do not get so much of bleeding as you would anticipate it to be. So maybe there is a rebalanced hemostasis playing the role, but there is really no data, showing it there except for liver, where it has been extensively studied for the PT, prothrombin time, and the PTT.
Samir, can I take one last question?
Yeah.
Just today I had a case, radius ulna. Patient was known case of DBT. Since 2 years, he was on tablet Xarelto, and he landed up with fracture radius ulna, himself a doctor. So I had advised them to wait for 5 days, do his PT-INR, and we did the case in. So was the approach right?
We lost you in between for a while. I couldn't
Yeah,
hear.
this patient was
What did you do?
DVT. He was on Xarelto for 2 years,
Right,
and he had fracture radius ulna to be plated.
right,
So he stopped it for 5 days, and I got his repeat Doppler done, which showed no evidence of DVT. But still, I
right,
put him on Plexane,
right.
and then we have did it in block today. So was that
Okay.
right approach?
Yes, absolutely. I mean, you stopped the Xarelto for adequate amount of time. The fact that the patient had DVT previously may predispose this patient to DVT again. So that's the reason why you've started the patient on low molecular weight heparin. And it's easier to control the low molecular weight heparin in the perioperative period. So I think you've done an absolutely perfect job. Now, the ASTRA, like I said, the ASTRA 2018 guidelines recommends that any of the blocks that you give, especially if they're deep seated and you do not have control over the vessel, ideal would be to use an ultrasound close to it or to treat them as neuroaxial block and follow the same guidelines.
Yeah.
Unless you probably chose, I don't know which block you gave, but if you're chosen an axillary, you could have even continued with alteparin.
Thank you, madam, for an excellent presentation.
Samir, there
uh,
is one question whether clopidogrel needs to be stopped before minor procedures like cataract or dental extraction.
So cataract, definitely, because again, it's a closed space. If there's going to be any bleeding from the iris or anything, I don't think the ophthalmologists themselves would operate on a cataract with clopidogrel ongoing. See, we're not giving any of the blocks anymore. It's all being done under topical.
I think with that, we proceed to our next topic of the day on precision filter. To discuss renal function test and the significance in the pre-anesthetic check, we have Dr. Amit Jain. Dr. Amit Jain is, are you there, sir? Dr. Amit Jain, please
Yes,
unmute
sir, I'm
yourself.
there. Yes, sir. Yes, sir. I can hear you.
Please start your presentation, sir.
Yes. Yes. I need to.
Dr. Amit Jain.
Yes, I need the.
Yeah, can you, Jenica Technologies, please, can you display Amit sir's slide? Yeah. He has done MD Medicine and DNB in nephrology. He has a 5 years experience as a consultant nephrologist and he is attached to Tunga Hospital, Galaxy Healthcare and HCG Apex Hospital. He is member of Mumbai Nephrology Group and Indian Society of Nephrology. He has received multiple awards and oral paper presentation in state and national conference. And he is a recipient of the Amar Gandhi Award in 2019 at Jaslok Hospital. Over to you, Amit sir.
Yes, sir. Sir, I need permission for screen sharing actually.
Yes, sir. Yes.
Yeah, please share your screen.
Yes. Is it visible?
Yes, sir.
It's visible, sir. You can
Yes,
start.
yes. Okay. Firstly, thank you, Rao sir, and all the presenters for organizers for giving me the opportunity to interact with everyone. So we will be discussing about significance of renal parameters in any general pre-anesthesia workup or pre-anesthesia. Even some parts we will cover about post-surgery and how various parameters impact the health of the patient. So I would like to segregate the entire spectrum of nephrology into categories like acute kidney injury, chronic kidney injury not on dialysis, chronic kidney disease not on dialysis, and post-transplant patients. So in our routine practice, we encounter maximum patients of acute kidney injury. So we will discuss first this segment in detail. So the first question is why AKI in surgical patients? Why there is acute kidney injury? So there are multiple reasons because the patient has hemodynamic instability. Some patients develop hypotension, hypertension. which disturbs the renal autoregulation and causes kidney injury. There is always in our country a lot of infective cases. If some cases are infective to start with, some cases develop infection later. All these infections can impact the kidney. A lot of nephrotoxic drugs are there which can be used, which harm the kidney. Antibiotics, radiocontrast dyes, and mainly painkillers. And obviously, patient can have pre-existing comorbidities, like diabetes, hypertension, heart disease, obesity. All these factors, even though creatinine is normal, they have some pre-existing renal disease which gets unearthed during any stressful situation. So how AKI disturbs the outcome of any surgery? It basically disturbs the metabolic milieu. There are disturbances in sodium. Kidney is a very versatile organ which handles sodium, potassium, calcium, acid-base metabolism, and most important, fluid metabolism. So all these parameters get deranged if our surgical patient develops an acute kidney injury. So as we have mentioned, disturbances in metabolic milieu, sodium, potassium, calcium, we have to monitor uremic effects.
Dr.
If there
Amit,
is
excuse me, can you move your slides, please? Your slides are not moving.
On my screen, they are moving, sir.
Sir, please first stop sharing, then again share.
Okay. New share.
Share the entire screen.
Okay. Is the slide moving now?
Yes, sir, moving.
Yes, now it's moving. Yeah. Thank you. Thank you.
Just a sec. Now my slide should move. No? Yes. So I'm sorry for the technical mistake. So uremic effects. Kidney plays a very big part in excretion of all the uremic toxins. And if there is an injury to the kidney, these uremic toxins have various effects on various organs of the body, like brain, heart, and respiratory system. Obviously, it affects AKI will affect the fluid status of the body. Patient might develop fluid overload, and hence perioperative, postoperative outcomes are hampered. BP fluctuations, because if kidney autoregulation is lost, kidney loses the ability to maintain a BP, and these patients frequently have very low BP and very high BP, and obviously acid-base dysregulation. All these things basically prolong the ICU and hospital stay. Just coming back to a little theory part, what is the definition of acute kidney injury? This is a KDIGO definition of acute kidney injury, which states that AKI is defined as on point number 1, AKI is defined as a 0.3 milligram per deciliter increase in creatinine in 48 hours. So 0.3 milligram increase in 48 hours, or 1.5 to 1.9 times the baseline in 7 days. Okay, so second stage 2 AKI is 2 to 2.2 to 2.9 times increase in the baseline. Third stage is severe acute kidney injury, like more than 3 times the baseline, or creatinine value increasing more than 4, or patient requiring dialysis. So what we learn from this criteria is that the baseline creatinine is of utmost importance. What was the creatinine before the surgery is very important. Only then we can define AKI. And if you notice, 0.3 milligram increase seems to be very normally slight increase. Some patients, suppose preoperatively, has a creatinine of 0.6, and then creatinine increases to 1. So it is well within the range, but still defined as AKI. The purpose is to make the healthcare team alert that this patient is at a risk of having kidney injury in future. The other parameter is also there, urine output parameter. So if output is less than 0.5 ml per kg per hour for 6 to 12 hours, stage 1 AKI, less than 0.5 ml per kg per hour for 12 hours, so it is defined as stage 2 AKI, and less than 0.3 ml per kg per hour for more than 24 hours, or anuria for more than 12 hours, is defined as stage 3 AKI. So when an anesthesia team approaches any patient, I would just like to mention that my entire discussion I have tried to base on very practical terms. I am not trying to cover any theory. I am trying to just brush up practical things that we do day in, day out. So whenever an anesthesia team evaluates any patient before surgery, what to address? Obviously, the first thing is volume status evaluation. As we were taught in MBBS schools, we have to go first clinical, then labs, and in the end, radiological evaluation. So clinically, we can see for edema, ascites, on auscultation, if there are crepes, we can examine the JVP, we can see the blood pressure. Then if the patient has a central line, we can check the central venous pressure. Hemoglobin report gives us a value, whether it is diluted, concentrated. Very important report is albumin. Now, albumin gives us a very good idea about the hydration status and about the nutrition status of the patient pre-existingly before the surgery. For any fluid overload or dehydration, we can check pro-BNP levels. We can do X-rays, sonographies we can do. Now, we can use POCUS, the sonography probes to check for fluid overload in the lungs. Kirby A, Kirby B lines can be checked. We can use a 2D echo, look for any evidence of dilated cardiomyopathy, pericardial effusion. IVC collapsibility, very commonly used parameter, which we use more often in our ICUs. And last, in the end, we can do CT scans and other scans. Other thing needs to be checked by the pre-anesthesia team is the metabolic milieu, calcium, sodium, potassium, and the acid-base abnormalities. Now, I would just like to brush on the frequent and confused parts of the evaluation. So whenever we check the calcium, we should always correct it for serum albumin. We know the formula, but in our busy practice, we always forget to correct for serum albumin. Formula is corrected calcium is 0.8 plus 0.8 into 4 minus serum albumin plus the serum calcium. When we are encountering with hypo or hypernatremia in any patient, now this is what we see very frequently. Any pre-anesthesia team sees that sodium is 120. Then what to do? First thing is we have to send the evaluation on day 1. As a nephrologist, what I feel is when I am involved in the picture, already so much either 3% NS is already given for hyponatremia or tolvaptan already started. The catch is to send to try to find the diagnosis. I agree, every time we will not get a diagnosis. But the catch is to try to find a diagnosis. We have to send serum osmolarity, urine osmolarity, and urine sodium levels. Even if we know it might be SIADH and tolvaptan works most of the time, but it is always better to try and document it. For any hyponatremia, we have to check for thyroid levels, cortisol levels. And while correcting hyponatremia, we have to be very careful about the rate of correction. That is the most important thing, because if we correct very fast, patient might develop central pontine myelinosis. So rate of correction should be 8 to 10 milligram per DL in 24 hours and maximum up to 18 milligram per DL in 48 hours. And always consider adequate pain relief and antiemetics, because pain and nausea are two very strong stimulators for ADH secretion. So they might cause SIADH kind of picture. Hyponatremia correction is very important and very frequent, which we do. The take-home message from my side is about hyponatremia is always try to diagnose and then correct at a slow pace. Other parameters which we come across is potassium dysregulation. So whenever patient has persistent hypokalemia, we should try and check for magnesium. If there is magnesium deficiency, how much ever potassium we give, it does not get completely corrected. Other thing which we should know is that sometimes I observe that people give 20 cc KCl and say, sir, फिर भी potassium is not increasing. Why it is not increasing? Daily requirement is 50 to 60 milliequivalents. And a 10 cc KCl has only 20 milliequivalents. Plus, we have to also adjust for pre-existing depletion, ongoing losses. Any patient in hospital or ICU, pre-operative patient, either is in pain, not eating well. So all these things need to be taken care of. Obviously, first preference we have to give to oral correction, and if very severe, then we can augment with IV correction. Difficult to treat hyperkalemia. Hyperkalemia, we all know, very important to be corrected before any surgical process, because it can cause cardiac rhythm disturbances. But I would like to brush up on type 4 RTA. This is some patients which we see, how much ever correction we give, the potassium levels are always high. The typical profile is they have metabolic acidosis, they have a normal anion gap, and they have hyperkalemia. They also have mild to moderate renal impairment. Creatinine might be between 1.5 to 2 to 2.5, like that. Most commonly seen in patients with type 2 diabetes and obesity. The typical profile of difficult to treat hyperkalemia. They do have type 4 RTA. So in type 4 RTA, there is a inability of the kidney to excrete potassium in the collecting ducts. We can check the urine pH. If urine pH is acidic, then it is suggestive of a mineralocorticoid deficiency. In such cases, fludrocortisone, external mineralocorticoid, will be very helpful to correct the potassium. But if the urine pH is high, it is suggests that the channel has been, there is a structural disease in the channel, which might be seen in diseases like obstructive uropathy, lupus nephritis, sickle cell nephropathy, interstitial nephritis, drug-induced interstitial nephritis, heavy metal-induced interstitial nephritis. So how do we treat such patients? First and foremost, which we always ignore, is diet restriction of potassium. We always give GI drip, we always load patient with bicarb, calcium. Diet restriction, very important. Scroll through all the list of medications if there's any medication which can cause hyperkalemia. So any ACE inhibitors, ARBs, even beta blockers to a certain extent can cause hyperkalemia. Heparin in some patients can cause hyperkalemia. Treatment wise, we can give fludrocortisone if urine pH is less than 5.5. We can give diuretics. Loop diuretics especially are known for potassium loss in the urine. Very important is to correct volume overload. That again with fluid restriction and diuretics, and very rarely alkali therapy is required. So take home message, what we do is we see hyperkalemia, load patient with potassium, already obese patient with fluid overload, keeps gaining more fluid overload and then goes for surgery, then ends up having poor post-surgical outcomes. Metabolic acidosis. Now this is one topic which is extensively discussed and very important, very interesting, which we should work up. I am just trying to simplify our day-to-day working. So my request to our entire team is to always try to work up before you treat acidosis. What I observe is in any ICU, in any pre-operative patient, if patient has a bicarb of 14, sir, मैंने 100 cc bicarb दे दिया. That is right. You have treated, but you have lost the opportunity to work up what kind of metabolic acidosis it is, whether it is high anion gap, normal anion gap, and there you have to try to find some cause. That will always help you treat the patient better. Anion gap is very easily can be very easily calculated. Sodium minus bicarb plus chloride. And this old formula of bicarb dosage, which is very famous and very commonly practiced, of 0.5 into body weight into 24 minus serum bicarb. I'm sorry to say, but if we follow this formula, we end up giving 300, 400 cc of bicarb, and we just end up loading the patient with so much sodium load that eventually patient develops fluid overload. So the working is, if a patient has a pH of 6.8 and a bicarb of 10, we can calculate the bicarb dosage, but give only half of the deficit first and customize for every patient, because we cannot go for overcorrection. The target pH to achieve is not 7.4. The target pH to achieve is 7.2. And obviously, if patient has renal dysfunction, if any metabolic acidosis is not being able to correct medically, we have to give SOS dialysis support also. Metabolic alkalosis is a very ignored subject, which not very harmful, but it does prolong the hospital stay. So there is a term called contraction alkalosis or chloride depletion alkalosis. So this is a particular term which happens if there is selective chloride loss, which happens in our perioperative patients. If there is excessive vomiting or aspiration, then in such cases there is increased bicarb generation along with inability to excrete the bicarb due to deficiency of chloride. Because in the kidney there is a chloride bicarbonate exchanger. If chloride is deficient, the bicarb is generated in excess, but it cannot be excreted and hence causes metabolic alkalosis. Metabolic alkalosis then causes muscle dysfunction. Such patients cannot be extubated early and we get poor perioperative results. So the catch here is to correct chloride depletion. We have to check for chloride, very commonly ignored parameter. Post diuretic alkalosis it also happens on similar principles. Post-hypercapnia alkalosis, which happens in our post-surgical patients, there is increased carbon dioxide leads to increased bicarbonate generation, but kidney tries to compensate. So there is increased bicarbonate generation and hence there is washout of chloride. So in all these cases, the treatment is simple, normal, saline. We have to replete chloride. Now coming to simple other renal function tests that we do, before any surgery we do prescribe urine routine. What to see in the urine routine? We always look for pus cells. Yes, they indicate if there is infection or no. Always send cultures early. This is a very sincere request because these days UTIs we get so many resistant bugs. If we send the culture on day 3, day 4, then we get the report on day 5, day 8, day 9. Then by that time it's too late. Even if patient has 10 pus cells, send culture on day 1. It is better to get a negative culture report rather than to send a culture on day 4 where already some antibiotic has been given for 3 days and now we are sending culture. If we find RBCs in the urine, then a very important and simple test we can do is check for dysmorphic RBCs. It's a very simple test, cost is around 100 rupees. It tells us what is the source of the RBCs. If the RBCs are coming from the glomeruli, then it is indicative of some glomerulonephritis. In such cases, when the RBC travels through the renal tubules, the structure gets distorted and the RBCs are dysmorphic. So we get dysmorphic RBCs and RBC casts. Whereas if there is a stone in the urinary system, those RBCs will not be distorted. So it is very helpful to understand. Simple test helps us understand what is the source of the RBC. Always look for proteinuria. A lot of patients have +1 proteinuria, we ignore, but in the back of our mind, we should know if creatinine is normal and patient is showing +1 proteinuria, there might be some ongoing kidney disease, which might get ignored. And obviously in a state of urine infection, proteinuria cannot be evaluated. It's not the correct time because infection can precipitate proteinuria. So we should never send a urine protein creatinine ratio during an active infective state. What to see in a sonography abdomen? So we always see the kidney sizes. Very important parameter which we look at is the corticomedullary differentiation. So it tells us whether structurally the kidney is good or no. If there is loss of corticomedullary differentiation, it is definitely suggestive of chronic kidney disease. Obviously, we look for obstruction. Cysts. Cysts is a very common thing. A lot of patients come to OPD with cysts. There's a lot of anxiety. We have to assess. There's a classification, Bosniak renal cyst classification done on CT scans. Simple cysts can be easily ignored. Complex cysts need evaluation. Last thing is bladder status. We have to see the bladder status. Some patients have chronic cystitis. See, by seeing all this in a pre-anesthesia checkup, we get an idea that patient might have a UTI in the post-surgical state also. So we better start with the higher antibiotic. So all these clues help us serve patient better. Size of prostate we should always see. And one last thing which is ignored is always check for post-void residue in all patients. One very interesting and highly debated topic is contrast-induced nephropathy. A lot of anxiety, a lot of questions, a lot of confusion. I will just try to state what the guidelines say and what it is. So the contrast agents that we use are 3 types: hyperosmolar, isoosmolar, and hypoosmolar. Hyperosmolar contrasts are not used these days. So we are using Omni-PAC and all these are all isoosmolar agents. How they damage the kidney? These agents, radiocontrast dyes, are excreted by the kidney. When they are filtered through the glomerulus, they reach the tubules, they cause a osmolar load in the proximal convoluted tubule, and that once they reach the PCT, they cause tubular damage. So how to mitigate this? So the best method is to use minimum quantity of dye. You have to request your cardiologist or your radiologist to use minimum quantity of dye. There is a formula which says safe quantity of dye is 5 into body weight divided by serum creatinine. This is just a rough estimate, helps us define what is the maximum volume of contrast which we can give. Always avoid other nephrotoxic drug. If patient is planned for angiography or some contrast CT, and patient is on amikacin or some nephrotoxic drug, it's smarter to always switch over to a non-nephrotoxic drug and then go ahead with the contrast. What helps to prevent contrast injury is to avoid the increased osmotic load in the PCT. How we can do that? By hydration. So that's the only treatment, only proven treatment for contrast-induced nephropathy is to hydrate. So we have to give hydration. We can give 3 ml per kg per hour, 1 hour prior to the procedure to 6 hours post procedure. Or if patient has poor ejection fraction and all, we can give 1 ml per kg per hour, 6 hours prior to 12 hours post procedure. There is no role of mucomis. All studies are negative. There is no role of dopamine, no role of dialysis post procedure to remove the dye. Yes, you can remove the dye, but the damage is done as soon as the dye reaches the proximal convoluted tube. So there is no role of dialysis. We see a lot of times patient being counseled that, okay, we will give dye and then dialyze and remove the dye. So all that does not help. Coming to our other CKD population who are not on dialysis, chronic kidney disease, not on dialysis. So these patients have complex metabolic parameters. You know, they are always suffering from high blood pressure, hypertension, BP fluctuations. They have a lot of comorbidities. They have multiple diabetes, obesity, all these comorbidities are there. They are on multiple medications, and there are a lot of enzyme, interactions of these medications. There's a term called vascular senescence, especially in diabetic patients. The health of the blood vessels is not good, so these patients have higher risk when they go for any surgery. CKD in itself is a immunosuppressed state. So if I am evaluating a patient for pre-anesthesia who has a creatinine of 3, I have to understand patient has poor immunity, has very high risk of developing resistant infections because they keep getting infections. So might as well, I might get tempted to use a higher antibiotic from day one. They are prone for AKI and CKD. So this is the most vulnerable population which we have to take care, who are not on dialysis. So the acute or chronic injury might happen, and this injury is very unpredictable. So as when we are counseling patient before the procedure, any surgery is a stressful event. BP fluctuations can happen. Anything can happen during any surgery. We have to counsel the patients the extreme of requiring dialysis also in case something goes wrong. And obviously, we have to strictly avoid any nephrotoxic drugs in this population. CKD patients on dialysis, the issues are their nutrition status is very poor. They have multiple admissions, multiple antibiotics, drug resistance, access issues. These patients always have a fistula in one hand, so one hand cannot be used. Or if they have a perm cath, nephrologist will say, please don't use perm cath. So access issues are there. If I have to plan a surgery for a dialysis patient, it is ideal to dialyze him 12 to 24 hours prior to surgery. Concept is to optimize the metabolic parameters and fluid status, and always during surgery take care of HD access, whether it is perm cath or fistula, because that is the lifeline of the patient. The last part of our CKD population is post-transplant patients. So we have to understand that they are immunocompromised patients. They are prone to infections. They are on immunosuppressive medications. So we have to take care of drug interactions, drugs which alter the blood levels of tacrolimus, MMF, and steroid. They are even though they have undergone transplant, their creatinine might be 0.8. They are prone to developing AKI after any surgery. Things to take care is we have to continue the immunosuppressant drug even on the day of surgery. These patients commonly are on triple drug therapy, one calcineurin inhibitor, one MMF, and one steroid. So steroid we can give injectable, but MMF and tacrolimus have to be given even on the day of surgery. They have to be given. Injectable steroid cover till the refeeding starts, and always during any perioperative course we have to monitor the CNI levels, tacrolimus, sirolimus, cyclosporin, whatever drug patient is taking, we have to monitor. Okay, thank you very much for patient listening. If you have any queries, doubts, we can discuss.
Amit sir, thank you so much for an excellent presentation. I request Dr. Shilpa or Dr. Garud to take over the questions from the chat box.
Yeah, Dr. Garud can take the questions from chat box.
Yes, there is one question. For a CKD patient on dialysis, what would be the baseline creatinine level acceptable for elective surgery?
Sir, patient is on dialysis, so such dialysis patients do not have a stable creatinine level. So if I check the creatinine level, immediately after dialysis, it will be 2. Next day, if I check, it will be 4. Next day, if I check, it will be 6. So there is no baseline, there is no issue of baseline creatinine level for dialysis patients. They are actually very easy. They are simpler to manage than CKD patients who are not on dialysis. It's just that we have to plan our dialysis 12 to 24 hours prior to surgery, and then we can go ahead with. Once we optimize the fluid status and the metabolic parameters, we can go ahead with surgery.
Okay, thank you. And what is the preferred IV fluid in CKD patients, whether it is ringer lactate or acetate like Cabilite?
There were few studies actually for about acetate balanced solutions to prevent AKI. But unfortunately, large volume studies were conducted, and there were no significant differences between subgroups who used normal saline and balanced acetate solutions. So, and obviously the cost goes high. So, in our common practice also, and all guidelines, there are no guidelines to support use of balanced acetate solutions. We can use NS very conveniently. Ringer lactate we can use if potassium is within control.
Okay, thank you, sir. There is a next question. If a patient is planned for URS or PCNL and is already on antibiotic treatment for UTI, is it advisable to wait till urine culture is negative before taking up for urology procedure?
No. See, if patient is planned for a urology procedure with an active infection, then we have to attack the infection in both manners, with IV antibiotics also and with procedure also. If a URS is planned, suppose there is a stone, there is an obstruction, there is hydronephrosis. So we have to tackle both at the same time. There is no need to stop for culture reports. See, because culture reports might take more time, sir. Sometimes they come in 48 hours. Sometimes they take up to 5 days. It depends on what bug is growing. So absolutely, we should not wait for culture reports. We can go ahead with surgery with antibiotic coverage.
Thank you, Dr. Amit. That's all questions.
Thank you, sir. Thank you.
Thank you, Amit, sir.
Thank you. Thank you very much. Pleasure talking to you all. Thank you.
We'll proceed to our next presentation. Has Dr. Shashank Joshi joined, sir?
Yes, he has joined.
Yeah, it's a hidden surprise. He'll be talking on evaluation of endocrine disorders in the PAC. Sir, everybody knows Sir now after the COVID. He was one of the main persons of the COVID task force. Sir is a consultant endocrinologist at Leelavati Hospital, HN Reliance Hospital, and he's also practicing at Doshi Clinic. He has more than 1,000 publications to his collar, and he has topped almost all exams with gold medals. So he has received he's a recipient of the Padma Shri Award from Government of India in 2014, and he's an acclaimed International Clinician of the Year Award in 2012 from the American College of Endocrinology. He is the president of Indian Thyroid Society, president Indian Academy of Diabetes, past president International College of Nutrition, past president of Endocrine Society of India, past president Association of Physicians of India, and lot many posts that he holds. It will take almost 5 to 10 minutes to talk about, sir. So I would request sir to start with his presentation, sir.
So thank you so much. I must thank my batchmate, Dr. Rajesh Rao, who was a brilliant clinician himself, for asking me to talk. He has given me a mandate to talk on thyroid. And if I get some extra time, but now we are already running late by 30 minutes by Indian stretchable time, to give something on, beyond thyroid on maybe a pheochromocytoma or something. But I think I'm going to really focus on a couple of cases related to thyroid disease and surgery, because that is what all of you all see. So I'm going to do a reprisal of that. So I'll start with the case. This is a 58-year-old man presented with 4 months of history of epigastric pain. Endoscopy and histopathology revealed a lower esophageal squamous cell carcinoma. He had been diagnosed 8 years back earlier with hyperthyroidism had been treated with radioactive iodine, after which the thyroid functions were normal. They were stable during follow-up, and thyroid functions 3 days before operation were normal. Lung functions showed no signs of abnormality. The ECG showed a left anterior fascicular block. Echo, CT abdomen, CT chest were unremarkable. All other labs were, normal. So clearly, there was a radical esophagectomy with reconstruction, which was through the left thorax, which was performed successfully. Patient was stable during the first post-op dive, transferred out of ICU. Patient was treated with prophylactic antibiotics, received fluid support. And except for complaints of incisional pain, the condition remained stable. And by 40 hours post-op, patient began to suddenly become drowsy and have dyspnea. The saturation, he was desaturating, the oxygen saturation dropped down, the PCO2 was 45, pH was 7.22. Patient was intubated and put on mechanical ventilator, and support was given to maintain electrolytes and acid-base imbalance. Patient remained unconscious with respiratory function, which stayed unstable for next 2 days, with normal chest X-ray and normal CT brain. So, because the patient had history of hyperthyroidism and I-131 therapy, we considered a possibility of thyroid function abnormality after stress of operation. So, though the thyroid function tests were normal, you see this patient had history of hyperthyroidism with I-131 given. And the surgical stress, thyroid function test on day 5 of surgery showed a TSH of 14, a FT3 of 1.414, FT4 of 2.45. And we had to give an IV thyroxine, not easily available, 300 micrograms with a dose of 60 microgram daily was maintained. And patient's condition gradually improved. And day 2 after initial dose of thyroxine, the patient regained consciousness. And next day he was able to maintain effective ventilation and was extubated. And day 15 of post-op, patient was back on semi-liquid diet and was discharged on oral thyroxine therapy. So, people think that we don't see situations in clinical medicine. And, here if you see preoperatively, this is a typical, we never thought that this patient would, with a normal thyroid function test 3 days before operation, normal, still deteriorated, and you need to still check for thyroid functions. So this is a classical case of myxedemic coma, post-op, which is usually complicated, rare, and hidden. Because Rajesh told me very clearly, he gave me a mandate that you have to show something which is hidden, which is innocent, looking innocent, but can have a challenge. And therefore, strong recommendation is that physicians check, thyroid function tests pre and post-op both. Particularly when there are risk factors, and this patient had a risk factor. Then let's look at non-thyroid surgery in a patient with thyroid dysfunction, because this is what this typically is. This is increasing with age. We are seeing that thyroid disorders are very common. And the reason they are common because of autoimmunity. We are all consuming iodized salt, and the iodine in the salt is a immunogen. So it generates antibodies, and that is why Hashimoto's thyroiditis or autoimmune thyroiditis is on the rise. It is, of course, having a gender prevalence. So women to men ratio is almost 8:1. And, seriously ill patients often have abnormal thyroid function, which may or may not be clinically significant. Because one thing you notice that in critical care setups or acute care setups, often the thyroid functions are deranged. You need to recognize what is sick euthyroid syndrome versus what is normal thyroid versus what is abnormal thyroid. So some standard tips is never do T3, T4, TSH. And if you do T3, T4, TSH, do an albumin. And do free T3, free T4 and TSH. And if the free T3, free T4 is normal and TSH is above 10, it is clearly abnormal. But any TSH between 4 to 10 can reverse back, because that could be sick euthyroid syndrome. Typically, in a sick euthyroid syndrome, the T3 may vary much more because T3 is more biovariable than T4. So many a times we have to distinguish sick euthyroid state from a clinically significant euthyroid state. So as I told you that a significant number of people do not know that they have thyroid abnormality, and surgical stress may unmask a concomitant thyroid dysfunction. So we know that what should be the current practice for screening for thyroid dysfunction before surgery. because there is a high prevalence of thyroid disease in general population, generally it is not recommended. The general guideline is you don't need to do everybody's T3, T4, TSH. However, if there is a family history or history of thyroid disease in that patient in the past, then it is mandatory to do it and always examine for goiter. So presence of goiter or presence of family history allows you to recognize the need to screen. But general recommendation is not there. And even if there is a history of autoimmune thyroid antibody positivity, it may be worthwhile screening the patient. So in people with well-compensated thyroid disease, additional testing prior to surgery is unnecessary. So somebody we know is on thyroxine, the free T3, free T4, TSH is normal, antibody is negative. You don't need to keep testing it again and again. We know that they are normal, and the surgical stress at best will increase the thyroxine requirement maybe 12.5 or 25. That is something which we need to recognize. So is pre-op measurement of TSH still necessary? That's a big question. So what are the issues of thyroid disorder which impact or influence perioperative outcome? So in whom will you really do a TSH if there is thyroid disease? The first thing is if there is anemia. If there is anemia, and in India we see hemoglobin which are low. So any hemoglobin below 10, okay, and if the patient is hypothyroid, it is mandatory to do a thyroid function and be thyrovigilant. If the patient has decreased cardiac output, even with preserved ejection fraction with diastolic dysfunction, you need to be cautious in that patient, particularly if the patient is hypothyroid on thyroxine with a normal TFT. If the patient has any metabolic abnormality like a dyselectrolytemia, uncontrolled diabetes, you need to be cautious and careful. If the patient has hypoventilation or snoring, you need to be cautious and careful. And if the patient is persistently constipated, you need to be careful. So these are the 5 things which can impact peri-op outcome of people with thyroid diseases, particularly hypothyroidism on thyroxine with normal thyroid function. Anemia, or look at hemoglobin, look at the echo, particularly if there is diastolic dysfunction with preserved ejection fraction or low ejection fraction. Look at respiratory rate and hypoventilation and snoring history. Look at constipation and look at metabolic abnormalities, including dyselectrolyting. So clearly we know that, the hypometabolism can impact, the hypothyroidism and peri-op outcome. We know respiratory muscle weakness can lead to hypoxia and hypercapnia. We know decreased gut motility in hypothyroidism can cause constipation. We know hyponatremia can decrease the free water clearance and increase serum creatinine, and the RBC mass is reduced in hypothyroidism. So that's something which we need to recognize. There are no randomized control trials. We are in evidence-based medicine era. So there are no randomized control trials comparing surgical outcomes of hypothyroid patients versus euthyroid patients. All we have are retrospective cohort studies, prospective cohort studies, or case control studies. So remember that the high level of evidence is not there. Most of the evidence which is even there in your anesthesia textbooks or endocrine textbooks or medicine textbooks are all based on empirical evidence or low quality of evidence. They don't have RCTs where we have compared surgical outcomes of hypothyroid versus euthyroid patients. And when we look at overt hypothyroidism, where, what are the case studies suggesting? As I told you, myxedemic coma in the case which I presented is a very rare case. It's a rare but fatal post-op complication. But you can get intra-op hypotension, you can get cardiovascular collapse, and you can get extreme sensitivity to opioids, sedatives, and anesthetic agents. And these case studies exist, and there are printed literatures. If anybody wants these slides, I'll be happy to share the slides with my batchmate, Dr. Rajesh Rao, and he can share it with the group. Then the retrospective cohort studies suggest that there is in hypothyroid patients, there is increased incidence of intra-op hypotension in non-cardiac surgery. There is increased incidence of heart failure in cardiac surgery, and increased incidence of post-op GI and neuropsychiatric complications, including hyponatremia related complications. and they are less likely, even if they are having infection, to mount fever with that. So they may not be febrile at all post-operative. So that's something which you need to recognize, that somebody is overtly hypothyroid. There is an impact on outcome. And we have data to suggest during surgery and after surgery, some outcome data. Moderate hypothyroidism, if it is seen, and urgent surgery is required and it cannot be postponed, we can start thyroxine ASAP. And if it's a young patient, you can start the full replacement dose, 1.6 or 1.7 microgram per kg body weight. And it is not mandatory to give thyroxine every time on empty stomach first thing in the morning. You can give it whenever the patient is encountered first. Many a times patient is admitted in the evening. You can give the full dose, loading dose in the evening. If it is a young patient without any hemodynamic and cardiac compromise. So if it's an emergency surgery, load the patient with the full replacement dose if you pick up moderate hypothyroidism. If it's an elderly patient or a cardiac patient, then start slow, go slow and do cardiac monitoring. And start with 25 or 50 and increase the dose every 2, 4 or 6 weeks. This has to be very, very carefully titrated. However, if it's an elective surgery, then you can postpone the surgery and start thyroxine therapy and then ensure that after 4 to 6 weeks, you go for surgery again. Now remember, half-life of thyroxine is 7 days, 1 week. And usually for a steady state concentration of thyroid, it takes 4 half-lives. So that's something which we need to all be mindful of, that whenever we are replacing with thyroxine, you need 4 half-lives, which means 28 days to actually achieve. But when you load, you can prevent the catastrophic complications. So that is something which we need to recognize. So if the patient doesn't have hypoventilation, gut motility issues, sodium is normal, creatinine is normal, anemia is not there, and there is no major ejection fraction abnormality or diastolic dysfunction, it is reasonable to even go ahead with surgery. So those are the 5 points which I told you, which impact perioperatively the outcomes. You are reasonably certain to go ahead with it. The big question is TSH is abnormal, T3, T4 is normal. Okay, we have some data in this because many times our cardiologists and cardiac surgeons, we have data from prospectively studying the post-op outcomes from CABG and PTCA patients with known pre-op subclinical hypothyroid versus euthyroid patients. And we have not seen any major differences with major cardiovascular events, wound outcomes, mediastinus, leg infections, and respiratory complications. So that data is not there. So in subclinical hypothyroidism, where T3, T4 is normal, free T3, free T4 is normal, and TSH is borderline, but below probably 7 or 8. My cut point clinically in India is between 4 and 8. There is no need to postpone surgery in patients with subclinical hypothyroidism, particularly if there is a cardiac intervention required, a revascularization, either it's medical revascularization through PTCA or a CABG. That is something which we recognize as long as the free T3, free T4. Okay, so that is something which we recognize. So this was as far as the peri-op outcomes are concerned, hypothyroidism is concerned, an occasional case of mixed ischemic coma is concerned. Let us look at another case, because I think case-based discussions, the impressions are better, and all of you all are practicing anesthesiologists is what Rajesh told me. This is a 61-year-old lady, known case of hypothyroidism for 20 years, admitted with complaints of abdominal pain and distension for 3 days. She was found drowsy and arousable. Pulse was 68, blood pressure was 140/86. The temperature was 36.7. Respiratory rate was only 10. Hemoglobin was 8.8. WBC count is 12,400. Sodium is 112. Potassium is 2.2. Normal liver, kidney, X-ray chest, ECG shows low voltage complexes. T3, T4 is 62, 22.2 and TSH is 18. USG revealed a right iliac fossa mass, suggesting an appendicular lump along with a paralytic ileus. She was started with a conservative management of IV antibiotics along with correction of electrolytes and active rewarming. And her dose of thyroxine was elevated to 100 micrograms per day. So clearly you can see that the abdominal distension increased over a couple of hours. Contrast enhanced CT showed the intestinal perforation. She had to be immediately taken up for laparotomy. General anesthesia was induced using a rapid sequence induction. Immediately after the induction, she had a systolic blood pressure. She had intravascular hypotension with a systolic blood pressure of 85, which was managed with crystalloids. There was a further drop of BP during surgery, necessitating the need of dopamine and noradrenaline. There was a gangrenous colon. A right hemicolectomy was done, shifted to ICU for ventilation. When she received in the ICU, her temperature was 34 in hypothermia. Systolic BP was only 68. Deworming with warm fluids, bladder lavage with warm saline, electric blanket, 3 liters of ringer lactate was pushed IV, adrenaline infusion was now added. So clearly this is a published case. Thyroxine 50 micrograms once daily was given through Riles tubes. Gradually improved blood pressure over next 24 hours. Over next 2 days, inotropic support was given gradually, tapered off and stopped. TFT showed a marked improvement after 3 days. Thyroxine was then titrated from 500 to 150 micrograms twice a day. And then thyroxine dose was decreased further to 100 micrograms twice a day. And finally, on day 5 post-op, she was extubated and shifted to post-op ward. So this is the second case I'm showing you. By day 5 to day 7, you are able to pull off the patient. So it's a very reversible cause. So this was, the previous case was myxedemic coma. This was a myxedemic coma with sepsis. And peri-op thyroxine supplementation, that was IV, this is oral, can also alter outcome and prognosis. So it is not mandated because we don't have IV thyroxine easily available. You have to, beg, borrow, steal, go to Royal Chemist. It's not easily available and accessible. It is not that it's impossible. People can get it from abroad, but it is not freely available. But even with oral Riles tube, thyroxine tablets can be administered and you can save lives. So clearly in severe hypothyroidism, these are cases of severe hypothyroidism. These patients should be considered as high risk for surgery, and surgery definitely sometimes needs to be delayed until hypothyroidism is corrected. But sometimes you have emergency situations which I just described. If emergency surgery is a must in severe hypothyroidism, there is always a concern of existing or pre-existing myxedemic coma. And sometimes we also now have T3 tablets available in India. They are called as Linorma. They're available as 5 and 20 micrograms. And you can give a mixture of T3 and T4 tablets. When this case was described, there was no T3 available. Again, it had to be imported. Now, Abbott makes the Linorma or T3 tablets, 5 and 20 micrograms. You can give 20 micrograms with the thyroxine because the metabolite or the active thyroid hormone is T3. And post-op, patients receiving chronic T4 therapy who undergo surgery and are unable to resume oral intake. You can sometimes give it IV or IM, but usually what we do is we give 70 to 80% dose, or you can give it through Riles tube. Let me move gears to a geriatric case. 72-year-old male, COPD with cardiac failure, admitted to ICU with urosepsis, septic shock, intubated. TSH is 0.03, free T4 is normal, and total T3 is low. This is another common value which we see. So this is a typical non-thyroid illness. So again, don't get carried away by that low TSH, normal free T4, and a low T3. This is a typical scenario with sepsis in ICU, COPD, CHF, and intubated patient. And here we don't need to rush. This is a typical euthyroid 6 syndrome or low T3 syndrome, or a non-thyroid illness in which T3, T4, TSH is variable. And even if this person needs any surgery and a urological intervention, and this case is very similar to central hypothyroidism. It's a transient state. And many of these abnormalities are seen when you starve or fast, because the T4 and T3 is reduced because of caloric deficiency, because whenever there's a catabolic state in our body tries to conserve, and thyroxine replacement in such patients will worsen the catabolic state and will be deleterious and harmful. So in such a case where T3 is low, FT4 is normal, TSH is low, it is a typical sick euthyroid state. Do not give any thyroid medicine. Just wait and watch for the patient's recovery from appropriate antimicrobial and neurosurgical interventions. So remember, low T3 syndrome, why does it occur? Because fundamentally, we have different enzymes in our body which convert from T4 to T3. And these are deiodinases. And these deiodinases are two types, D2 and D3. And there is a decreased D2, which is the main activating enzyme, and increased D3, which is the main activating enzyme. And the decreased T3 and increased reverse T3 is seen. So in the good old days, they used to do reverse T3. Nowadays, we don't do reverse T3 at all. And there is a hypothalamic unresponsiveness. So it mimics a transient state of central hypothyroidism. It is very common in people with severe illnesses, in patients who are on steroids, beta blockers, amiodarone, and cytokines. So it's very, very common in that. And we see that. And you can see that there is a complete mess of thyroid function tests, particularly in critical ill situations. And in euthyroid 6 syndrome, there is a relationship between the severity and duration of non-thyroid illnesses with thyroid hormone levels. So how do you diagnose this low T3 syndrome? So it's typically called low T3 syndrome. Very, very low T3, normal or low T4. A low T4, low T3 is a poor prognostic sign. And a low TSH or undetectable TSH. And if facilities are available, sometimes we do a reverse T3 that is high. This test is clinically not available. We have to rule out a central hypothyroidism in the pituitary or hypothalamus. Usually that is not the case. And it predicts outcome. Only the low free T4 is associated with 85% mortality. So in the hospital or ICU, if you see the T3, free T3 is low, free T4 is low, and TSH is low, there is 85% mortality. So it's an outcome predictor. And in the recovery phase of any illness, we also sometimes see a low T3 syndrome. Because TSH increases to the upper limit of normal, T4 concentrations become normal, and T3 concentrations also become normal. So typically for non-thyroid illness, if a surgery has to be done, because your question is when surgery has to be done and anesthesia has to be induced, non-urgent surgery should be postponed. Because outcomes here, though we don't intervene, okay, we are looking at overall catabolic status of the body. The outcomes can be poorer. And we need to monitor thyroid functions, though no intervention is required because they don't have underlying thyroid disease. But the outcomes could be poor. Deferring of surgery may be needed, unless, of course, the surgery is emergency and mandatory. Sometimes this transient central hypothyroidism due to non-thyroid illnesses, thyroid functions usually return to normal, but very rarely, maybe 5% of cases may have central hypothyroidism. You might have a pituitary macroedema, occasionally can be seen. So MRI is sometimes done. If diagnosis is not cleared and surgery cannot be postponed, then we empirically give thyroxine and give perioperative steroids, because sometimes you might get some clinical evidence suggesting hypothyroidism or personal history of hypothalamic or pituitary dysfunction. So always ask in a woman history of postpartum hemorrhage, because they may have Sheehan syndrome, and always ask for history of central irradiation in childhood or adults. Was any radiation given to the brain? So these are two important historical points. In such situations, if surgery is recommended, ask these 2 points from a clinical standpoint. In absence of any suspected myxedemic coma, repletion should be very cautious. You always start with half of the full replacement dose of T4. Usually that is, instead of 1.6 microgram per kg body weight, we start with 0.8 microgram per kg body weight in the young individuals. And if they're elderly or cardiac patients, start with 24 or 50. And as I said, occasionally you might have to rule out central hypothyroidism for pituitary adrenal axis. And therefore, sometimes we often tend to give them with IV hydrocortisone cover, and a pituitary imaging like MRI may be required. What about hyperthyroidism? So these were all cases related to hypothyroidism. What about hyperthyroidism? I know I'm mindful of my time. Hyperthyroidism, the surgery should be planned only after achieving euthyroid states. Because all elective surgery should be postponed in people with newly discovered hyperthyroid states. Unlike hypothyroidism, where we can actually give thyroxine, give steroids, and get the patient out, even if we have normal thyroid function and they crash, we can still have very good outcomes. Because there's a lot of reversibility there. Okay. In hyperthyroid states, which are overt, which means increase FT3, FT4, low TSH, usually try to achieve euthyroxine state. However, if the TSH is low, FT3, FT4 is normal, you can typically proceed with elective surgery. So any subclinical hyper state, you can proceed with elective surgeries, but in overt states, avoid it. So if there's urgent surgery, and if there's hyperthyroid state, if there is no contraindication for beta blocker, you can use a long-acting beta blocker, atenolol 25 to 50 milligram and titrate it by pulse rate around 80 minutes. Or you can give IV esmolol or propranolol, 0.1 to 1 milligram over 10 minutes, followed by 1 to 2 milligram over 10 minutes to control fever, hypertension, and tachycardia. And sometimes we start methimazole or carbimazole. Both are available, but both are preferred over P2 except pregnancy because it's a little longer duration. And if hyperthyroidism is very severe, sometimes we use SSKR, potassium iodide solution, 1 to 3 drops or 5 drops twice a day, 1 hour after giving thionamide, which is methimazole or carbimazole. Both are available. Whenever there is a known or suspected goiter, multinodular, iodine in absence of thionamide will block the organification and will exacerbate the hyperthyroidism. So always remember that start the thionamides first, the carbimazole or methimazole first. 1 or 2 hours ke baad you give the iodine solution. Otherwise, it may be catastrophic. And typically, if there's a toxic multinodular goiter, because you know that iodine also reduces vascularity of the gland. Okay, who are intolerant to thionamides, beta blockers alone can be given. And Graves' disease patients who are intolerant to thionamides, we sometimes just give beta blockers and iodine. Lugol's iodine used to be available in the past, and we can easily go ahead with the surgical option. Rajesh did mention to me, and I'm mindful of my time, that do a little bit of glimpse of thyroid storm. So myxedema coma I started with, I'm ending with thyroid storm. Thyroid storm is a rare complication of hyperthyroidism, 1 to 2% of cases with a high mortality of 20%. Mortality has come down now. When it occurs in surgical patients, the mortality is the highest. Usually 10 to 20% are conservatively treated. And in operated patients, the perioperative mortality is very high, 30 to 75%. Usually in surgical patients, thyroid storm is a unrecognized, untreated hyperthyroidism. You get thyroid storm. And that is why I told you that in hyperthyroid state, if it is overt, delay or defer surgery. Usually it occurs 6 to 24 hours after surgery and can also occur during surgery. So it's something which we need to recognize. What precipitates thyroid storm? Well, medical conditions like infection and sepsis, cerebrovascular accident, myocardial infarction, congestive cardiac failure, embolism, visceral infarction, emotional stress, maniac crisis, major trauma and surgery, and drug-related conditions like I-131 therapy, premature withdrawal anti-thyroid drugs, exogenous consumption of thyroid hormone, iodine contrast agents often which we use for various imaging procedures, amidodone therapy, iodine injection, anesthesia injection itself, and sometimes drugs like pseudoephedrine, which are common cold agents, organophosphorus or aspirin and chemotherapy. So there are a lot of precedents for this thing. Historically, these are questions which you can ask for any thyroid disorders, but they are pertinent for thyroid storm. Is there history of thyroid disease? Are there symptoms of tremor, agitation, weight loss, nervousness, heat intolerance, proximal weakness, palpitations, or menstrual irregularity? Please, I'm repeating these symptoms because sometimes the thyroid hormone reports may be absolutely innocently normal. And the reliability quotient of thyroid hormone, though they have improved over a period of time, can be very erroneous. You send thyroid of the same sample to 3 labs, you will get 3 different reports. So I lay a lot of emphasis on subtle symptoms like tremor, agitation, weight loss, nervousness, heat intolerance, proximal weakness, palpitations, menstrual irregularity. Is there any history of thyroid manipulation? Is there any history of too many medication changes? Is there trauma, infection, or overt exertion? Is there history of recent anesthesia or recent iodinite contrast agents or any infectious syndromes? All of them can alter and historically should be asked in evaluation of thyroid storm. Typically in thyroid storm, you will see a low TSH and increased thyroid hormones, hyperthermic state, sometimes very high hyperpyrexic states, agitated patients, heart failure, SVT, atrial fibrillation, and tachycardia. And in the DD, the intraoperative tachycardia, hyperthermia, hypertension, the DDs are, of course, typically seen in anesthesia world. Pheochromocytoma, which Rajesh wanted to highlight, but I don't think I'll get time to highlight that. Neuroleptic malignant syndrome and malignant hyperthermia, which I think you all are experts of, and you all see that quite often. But don't forget thyroid storm. It can occasionally be seen. You can get unusual presentations of thyroid storm. For example, thyroid storm can just come as status epilepticus. It can just come as non-embolic cerebral infarction. It can come as abdominal pain with fever. It can come with rhabdomyolysis and acute renal failure. It can come with coma without any prominent cardiovascular findings. And the treatment of thyroid storm is simple. Start with beta blocker, propylthiouracil or carbi or methimazole. You know, methimazole and carbimazole are pro-drugs, and some hydrocortisone. So that is standard of care. 1, 2, 3, beta blockade, anti-thyroid drugs, and steroids. Second line therapy is lugol, potassium iodine, or sodium iodide. Lithium is another drug which is available with us, and L-carnitine. And supportive therapy if needed, oxygen support, ventilator support with IV fluids. Dextrose solutions are preferred to cope with the high metabolic demand because it's a catabolic state. Correct electrolytes, treat cardiac arrhythmias, and control hypothermia with ice packs, cooling blankets, and paracetamol. Sometimes, if they are non-responders, thyroid storm can be very difficult to treat. Plasmapheresis or plasma exchange, peritoneal dialysis or charcoal hemoperfusion, and emergency surgery, including partial or total thyroidectomy, can help in non-responding thyroid storms. So, thyroid storms also outcomes worldwide have improved. So, you know, those 85% mortality has come down to almost 20%, and that has come down to 10% in many centers across the world. So, post-thyroid surgery hypothyroidism in patients with normal thyroid function, recommendations for its management. So, this is something which we recognize, and there are a lot of studies to show that patients who have underwent a thyroid lobectomy for benign disease, okay, where pre-op hypothyroidism patients were excluded. Hypothyroid patients have a significant higher mean pre-op TSH level compared to euthyroid patients. And patients who develop hypothyroidism also had a lower mean pre-op T4 level. So clearly we see people with Hashimoto's thyroiditis who undergo a thyroid surgery have 4 times more likelihood to get post-op thyroid hormone replacement therapy. And this is something which we know very well. And with each increasing level of pre-op TSH, there is a large proportion of patients who require thyroid hormone replacement after a thyroid lobectomy. So when we do after a thyroid surgery, thyroid replacement therapy, we have to select the hormone preparation, sometimes T4 or T4 and T3, sometimes combined with iodine, look at the therapeutic TSH ranges, because if there is surgery for thyroid cancer, we try to keep the TSH between 1 and 2, lower the better, and extent of residual thyroid tissue after goiter surgery, underlying conditions and drug interactions. So you need to be very, very mindful of what you're doing. We do have T3 available in India. As I told you, 5 and 20 micrograms is available. It is not a routine. Sometimes giving T3 as a replacement is unphysiological. It is less well tolerated because you know that the mono and deiodinization causes peripheral conversion of T4 to T3. So usually there is no need to convert T3, but sometimes we need it. So sometimes we can combine the two. And clearly there have been RCTs in this space where we have combined T3 and T4. And you know, with respect to well-being, cognitive function, quality of lives, there have seen improvements. Because there are patients of ours who have a low peripheral deiodinize, which respond better to a combined therapy than T4 alone. So remember that replace thyroid hormone with a low dose. Dose has to be individualized. In elderly people, cardiac disease patients, long-standing hypothyroidism, start with weekly increments of 25 micrograms after initial 25 micrograms. However, young patients with good general health who undergo thyroid surgery, you can rapidly raise the dose post-operatively. And within 5 days post-op, you can go to the full dose. Okay, hormone replacement is always necessary if there is less than 6 ml of thyroid tissue left after surgery. So if there's a very small chunk of thyroid tissue left, usually you need thyroid hormone replacement. And usually the practical approach is to start post-operatively a dose of not 1.6, which is a typical hypothyroid dose, 1 microgram per kg body weight, and then monitor the TSH after 4 to 6 weeks. So if you want to play safe, then start with 1 microgram per kg body weight dose. So hypothyroidism immediately after surgery or residual thyroid volume less than 6 ml, 1 microgram per kg body weight of thyroxine with iodide, usually 100 to 150 microgram per day in otherwise healthy adults. If it's pregnancy, 20 micrograms, and follow every 4 weeks for a TSH between 1 to 2. If the patient is euthyroid after surgery and the residual thyroid volume is more than 6 ml, then you can sometimes just give iodine and follow up for TSH after 1 to 2 weeks. After surgery for autoimmune thyroid disease, which is Graves or Hashimoto's disease, usually we give thyroid replacement without iodine and follow up after 4 to 6 weeks. When there is total thyroidectomy, either for benign disease or medullary thyroid cancer or anaplastic thyroid cancer or any thyroid cancer, usually we replace thyroxine without iodine because we have to do an iodine scan afterwards. And here we try to keep the TSH between 0.5 and 5. After total thyroidectomy for papillary and follicular cancer, which is very common now, if iodine therapy is planned, then we don't give thyroid hormone replacement. We wait for 2 weeks, then do the whole body I-131 scan, and then give radioactive iodine 30 to 100 micrograms, and then we start thyroxine. If ablative radioactive iodine is planned at a later time after surgery, then sometimes we start with T3 replacement, 20 micrograms 3 times a day until the radioactive treatment is performed, because T3 half-life is shorter. So it shortens the phase of endogenous TSH stimulation. And we also have thyroglobulin injections available, which can be used for cases. My last point before I close out is on congenital hypothyroidism, because TSH values in neonates, preterm and mature, are very, very different. And we need to screen for TSH. And remember that a TSH 1 to 4 days, normal TSH is below 39. If you see a value below 25, 25 to 50 and above 50 is abnormal. 25 to 50 could be normal, could be abnormal. And after 2 to 4 weeks, then the TSH value drops down to 10. So many a times in a neonate, if you see a value of 8, 10, you need to be cautious and careful because it depends upon the gestation and age-specific reference intervals. So typically in a term baby, full-term baby, between 3 to 5 days, if you do a filter paper TSH, if it is below 10, it is normal. Only you might miss out a pituitary hypothyroidism. If it is above 20, then do a free T3, free T4 TSH and confirm congenital hypothyroidism and start them on therapy, because it's a reversible cause of mental retardation of platelism. If the TSH is between 10 and 20, then you need to recheck it again. I just wanted to make that point because people who do pediatric surgery and neonatal surgery, one needs to be mindful of that. I have tried my best in the limited time given to me, give you some ideas about some thyroid related conditions with anesthesia and surgery. I hope it was useful. I'm sorry I have maybe short up my time by 5 to 7 minutes. I'll be happy to answer if there are quick questions, 1 or 2. Rajesh, I don't think we have time for pheochromocytoma. We're already running late. I would have loved to talk on that, but maybe I will send you a video of that and you can circulate it in your group.
Yes,
I have
yes.
a full presentation of 15 minutes on
Or
pheochromocytoma.
maybe at a later day, maybe we'll have one lecture on that topic by you. But first of all, let me thank you very much. Shashank has been my batchmate. We go back 40 years. And just one message to him, he said, okay, I will do it for you. And he has done a wonderful job as expected. Very practical, excellent topic and excellent presentation. Dr. Garud will take questions from the chat box and Dr. Shilpa will ask questions if any.
Yes, excellent presentation, Dr. Shashank. There is one question that sometimes patients with hypothyroidism posted for surgery, they are clinically they are on treatment with hypothyroidism, but still TSH is high, say 75 or 80. So what should be done about surgery?
If it's an elective surgery, one would defer it. 75-80 is a very high TSH. But remember, TSH is a pituitary hormone. It's not a thyroid hormone. If your FT3, FT4 is normal, and if the surgery is compelling, you are reasonable to go ahead with it. But usually, if the TSH is below 20, I would be more comfortable. At 75 and 80, if the echo, ECG, it has to be an individualized case. If it's a compelling surgical indication, I may go ahead with it. Otherwise, I'll wait for 6 weeks. Because remember, I told you half-life of thyroxine is 6. It takes 4 to 6 half-lives to normalize. But if the surgery is compelling, you can go ahead, because as I told you, you can then, but you will need to monitor post-op and you will need to be mindful of intravascular hypotension and so on and so forth. But I agree that the TSH has a lag. So this, what Dr. Jyoti has asked that question, there is always a lag of TSH and correction of So T3 gets corrected first, then T4 gets corrected, then TSH gets corrected in hypothyroidism. And it is a reverse in hyperthyroidism.
Sir, excellent presentation. It is as if that we would like to continue hearing you, and you can go on speaking for a long time and other topics to come. And I think we need to go over your presentation 3-4 times to completely absorb what you have conveyed to us today. Thank you so much, sir, for being with us. Thank you very much, sir.
Thank you, sir.
Let's move on to our next topic. I invite Dr. Pallavi Vaghalkar. Today is a new topic for us. She'll be speaking on patient scorecard, scoring systems in pre-anesthetic checkup. Dr. Pallavi is an additional professor belonging to the Department of Anesthesia, KM Hospital, Parer. She is ACLS trainer and with keen interest in ACLS training. Over to you, ma'am.
Good evening, everyone. Am I visible and audible?
Yes, ma'am.
Can I share my screen now?
Yes, please go ahead.
Is it visible?
Yes, ma'am, we can see you.
Okay. Myself, Dr. Pallavi Vagharkar. First of all, I would like to thank Indian Society of, I say Borivali and SAMS for, giving me this opportunity to talk upon patient scorecard, PAC scoring system. Greetings from my institute, KM Hospital, Parel, Mumbai. Overview of my talk will be why the scoring systems are required in pre-anesthesia checkup. What is the ideal scoring system? What are the risk stratification tools in anesthesia? What are different scoring used in normal pre-anesthesia checkup and summary? So PAC is a like why PAC is important because we can develop a doctor-patient relationship. We can talk to our patients, collect a patient data, relevant data, so that we can have a proper anesthesia plan. And according to the patient status, we can, modulate our consent, whether it is a high-risk patient or a low-risk patient, what all investigations we should ask, that we can plan. So the steps can be, first of all, problem identification in particular to patient, then risk assessment for that particular patient, pre-operative preparation according to the case or a patient, and then plan what anesthesia technique we are going to use. So why risk prediction is important? By National Emergency Laparotomy Audit, it was found that patients who were not risk assessed preoperatively did not receive the required standard of care. The patients, we can assess properly. If it's a high risk patient, then we can be more vigilant and more standard of care can be given. The risk documentation also helps patients and their families to appreciate the implications of surgery, and it will help us to have a multidisciplinary decision making. Though our clinical judgment is important, but alone clinical judgment is not enough to predict the adverse outcomes post-operatively. So we need some scoring system, we need some predictors to do that. And therefore, these risk prediction tools were developed to identify the high-risk patients. Ideal scoring system will be the routinely available patient variables. It should be easily accessible. It should be rapidly done in PAC, should be extensively validated in different populations, and accurately it should be predicting post-operative outcomes, and it should have a high sensitivity and specificity. But such a kind of risk prediction tool is not available. We can say there are many tools available we can look at now. So what makes a good risk prediction system? The risk prediction system can be, specific about patient, about functional status of the patient, what comorbidities the patient have, what is the immediate health status of the patient. It also should consider the procedure patient is undergoing, the type of procedure, how invasive it is, the urgency of the procedure, and also the care team and the facility available around, what kind of equipments are there, what are the resources available. So these scoring systems, how they can change the practice, if this scoring system will be important for optimizing. Look, we know that by scoring system, this is the high risk patient, so we can optimize the perioperative conditions. From anesthesiologist point of view, we can identify high risk patients and a better risk prediction. Patient counseling can be done according to that. Informed consent, and we can mention about what are the risk factors and discuss with patients relatives. Appropriate referral to the higher centers, also compare among the different hospitals and unit, and also this risk prediction will be helpful for the quality control in a patient outcome. So the risk assessment tools on the literature, there'll be risk scores and there'll be risk prediction models. Now risk score is places the patient on a scale that will allow the comparison with others, comparison in the population based. Simple to use, but it doesn't give us the individualized risk prediction of an adverse outcome. That this patient, in this patient, this will be the adverse outcome. That individualized risk is not given. Risk prediction models will be, we have to enter the individual patient's data into the multivariate risk prediction models. It will be accurate, but disadvantage it is more complex to use in our routine clinical practices. So we'll look at first risk scores. Population-based mortality score is the commonest one, which is American Society of Anesthesiology Physical Status, ASAPS. Risk score for the cardiac perioperative complication is Lee's RCRI, that is Revised Cardiac Risk Index. And the risk score for the pulmonary complication, the recent one is Assess Respiratory Risk in Surgical Patients in Catalonia, that is ARISCAT score. So about ASA, this is the recent article. I had to look for the ASA scoring. Something about history. In 1940, Sackler, Taylor, and Rovenstein, they had this ASA physical system status classification to study, examine, experiment, and devise a system for the statistical data collection of the anesthesia. These are the pioneers who developed ASA. In 1961, Drips et al. Came into this 5 grades of ASA, which we have also used for a long time. First one is normal healthy patient, to grade 5 of moribund patient, not expected to survive with 24 hours with or without surgery. In 1983, the 6th category of ASA 6, that is brain dead patient, was added for the organ removal surgeries. In 2014, ASA added number of illustrative patient example in each category, and in 2020 they added pediatric and obstetric patient examples for each category. So this is the recent 2020 ASAPS status scoring, which includes adult example, pediatric and obstetric examples. This ASA physical status, according to the grade, they have given the mortality. As you can see, the ASA 5 patient, the mortality can be 9.4 to 51%. Just an overview about this ASA grade, which is a commonest scoring system. The ASA 1 will be a normal healthy patient, no organic, physiological, psychiatric disturbance, non-smoker, no or minimal alcohol use, excludes the extremes of ages, healthy, good exercise tolerance. ASA2 will be a patient with a mild systemic disease, no functional limitation, and has a well-controlled disease of one body system. So that current smoker, social alcohol drinker, normal pregnancy is ASA2, obesity of BMI between 30 to 40 is also ASA2, and well-controlled medical diseases. ASA3 is a patient with a severe systemic disease. Some functional limitation, has a controlled disease of more than one body system or one major system, but there is no immediate danger of death. So the examples will be poorly controlled diabetes, hypertension, COPD, morbid obesity of BMI more than 40, history of MI, CVA, TIA, or stents, cardiac stents more than 3 months. ASA4 will be the patient with a severe systemic disease with a constant threat to life and has at least one severe disease that is poorly controlled at or at end stage with possible risk of a death. So the recent or less than 3 months of MI, CVA, TIA, ongoing cardiac ischemia, severe valve dysfunction, severe reduction of ejection fraction, and uncontrolled medical diseases, sepsis, etc. comes in ASA4. 5 will be the moribund patient who is not expected to survive without operation. He is not expected to survive more than 24 hours without surgery, imminent risk of death. Surgeries like ruptured abdominal thoracic aneurysm, massive polytrauma, intracranial bleed, or ischemic bowel disease, bowel surgery. Sixth ASA grade, as we know, is a branded patient for the organ removal. And whenever, if even the ASA grade 1 patient coming for some high risk surgery, emergency surgery, like a ASA1 guy coming for a polytrauma, we can add E for any ASA grading. In 2020, they have added obstetric patient also. So in ASA2 becomes a normal pregnancy, which is well-controlled gestational hypertension, controlled preeclampsia without severe features, diet control, gestational diabetes mellitus. While ASA3 will be preeclampsia with severe features, gestational diabetes with complications, and thromboembolic diseases. ASA4 will be preeclampsia with severe features, maybe HELP syndrome. ASA5 will be uterine rupture. So why this ASA we have to use that? It really helps us to evaluate the degree of patient sickness or the physical status before selecting any anesthesia or performing surgery. It is also helpful for us for communicating between the colleagues. Rather than giving the whole lot of history, we can just give that this is the ASA3 patient. When we are giving some over of a surgery, that terminology can be used. Allocating the resources depending upon the ASA status, record keeping, and uniform system for the statistical analysis. The ASA is very good. But this grading system is not intended for use as a measure to predict the operative risk. Like for example, if a 50-year-old female patient, BMI 34, hypertensive, scheduled for shoulder arthroplasty becomes ASA2. 50-year-old female patient with end-stage renal disease on intermittent dialysis scheduled for esophageal gastroduodenoscopy becomes ASA3 patient. And 50-year-old female for CAD with coronary artery disease recently with anterior MI scheduled for excision of skin lesion with local anesthesia becomes ASA4. But why the outcomes of this data of ASA grading, as we can see that ASA4 has a higher mortality and death rate of 11%. It is not justified when the ISA4 patient coming for the local anesthesia or under sedation, we cannot tell that they have 11% risk of death. So ASA grading is just for the statistical or the patient-related risk factors. It doesn't include the procedure-related or a care or the facility-related factors which are there. So just to revise up the ASA grading, can I ask this question and just the audience can put the answer in the chat box? Like a 35-year-old woman scheduled to undergo elective surgery to remove a large ovarian cyst, comorbidities including anemia from menorrhagia and type 2 diabetes treated and controlled with metformin. She is a non-smoker and occasional social drinker with BMI of 42. So what is the ASA physical status of this patient? Can we have answer in the chat box? I'll not take much time. Somebody can help me. What is the chat box? Okay, I can see the chat box. Okay, the answer is ASA3, as we have seen just now, that BMI 42 is the ASA 3 grade. So she becomes the ASA grade 3. So I'm not able to, yeah. So that was about ASA. The next risk score is the Lees RCRI, which is extensively validated for predicting perioperative cardiac risk in non-cardiac surgery. So they have included these 6 parameters: the coronary heart disease history, high-risk operation, heart failure, cerebrovascular disease, insulin-dependent diabetes mellitus, and serum creatinine value of more than 2. Each parameter has been given a 1 point. So highest the score, there'll be like the more than 3 points, there'll be 11% risk of this major adverse cardiac events like MI, pulmonary edema, arrhythmias, ventricular fibrillation, or the cardiac arrest. The assessing respiratory risk in surgical patients is a new score, ARIS-CAT score, which is a population-based surgical cohort of 2,464 patients was studied for the development of post-operative pulmonary complications. And they included this, they have included all these pulmonary post-op complications with the composite measures of all these parameters: respiratory infection, failure, pleural effusion, atelectasis, with adverse outcomes such as pneumonia, ARDS, or pulmonary embolism. So they have considered these 7 factors to score these patients as age of the patient, preoperative SpO2, respiratory infection in the last month, preoperative anemia, what is the surgical incision, what is the duration of the surgery. So this, if there is a score is high, then it is more than 45 score, then there is a high risk for the patient. The advantages of this ARISCAT score is some of this can be used for elective setting surgeries. Like there are some modifiable factors like anemia and the respiratory infection. So we can optimize that. But it is, you can see that the definitions of pulmonary complication post-op shows some heterogeneity. So clinical use, routine clinical use becomes difficult. These were the risk scores. I talked about risk prediction models, which are PPOSM, NELA, SORT, and ACS, NSQIP. Let's look into that. POSM is physiological and operative severity score for the enumeration of mortality and morbidity was used in 1991. It was included for emergency as well as elective procedures for gastrointestinal, hepatobiliary, urological, and vascular surgery. And for different surgeries, there are different scores online. That is PPOSM, then there is vascular surgery POSM, and other surgeries also. But it mainly includes the physiological variables and operative variables. Physiological variables like age, cardiac signs, respiratory history, X-ray findings, BP, heart rate. They have also included the Glasgow Coma score, hemoglobin, urea, sodium, potassium, and creatinine. They have also considered the operative variables like operative severity, multiple procedures, total blood loss, peritoneal soiling, presence of malignancy, and urgency of surgery. So the advantages of this POSM is it is a very comprehensive and well validated score, which has been validated in many of the studies. Data can be used for elective and emergency procedures. It had included the physiological status of the patient. But this operative findings limits its use in a preoperative decisions because there are some subjective physiological variables also. So sometimes it overestimates the risk in some groups. The National Emergency Laparotomy Audit, this POSM is also available. The POSM variables were used for this audit of National Emergency Laparotomy Audit. Both NELA and POSM are available online as a smartphone app, so that we have to just feed up the patient's data and then the score is available. The NELA will be accurate, specific for the emergency laparotomy, and it requires the same data which was required to feed up for the POSM, but it is again a time consuming and it requires the estimates of intraoperative findings, and no morbidities component has been studied. All these are 30 days mortality was the outcome for all these prediction modules. This is the small surgical outcome risk tool, also available as an app, where you have to fill up these 7 parameters like, type of ASA, grading, urgency of surgery, what is the surgery, risk of malignancy. So these 7 parameters you have to fill up and then it will give us the score. It is a simple model available online again as a calculator, but it has a limited scope. Again, it is only considers a 30-day mortality. No morbidity is considered. And it doesn't include the high-risk surgeries like obstetric, neurosurgery, cardiac or transplant surgery. And factors like BMI, hemoglobin, creat is not being used. This is the extensive American College of Surgeons National Surgery Quality Improvement Project is a validated risk prediction tool used in USA, where it concludes the 21 preoperative factors to predict the 14 outcomes within the 30 days of surgery, but mortality as well as serious complication post-op also considered in this, and some of like return to operating room discharge criteria. So you have to fill up this all the 21 parameters in this online, and it will give us the score. So this considers the preoperative variables. It considers the morbidity as well as mortality. Thus, it will help us, to have a decision making. We can tell to this patient that, according to this score, this patient is of this much score, high score, so this is high risk patient, and that's why we are asking so many investigations, and that's why we are take high risk consent. ICU is required. That can practice can be done. So it is available online, but it is a expensive. You have to pay for it. The free trial is after that. The extensive scoring is you have to pay. Dedicated data collectors are required, and that data mostly is used in a sector of USA. So the applicability to the other population and other studies has to be studied. So this is the summary of PPOSM, NELA, SAW. These are ACS, NSQIP. These are all different scoring system. You can say that they study the 30-day mortality, and they are very comprehensive and time-consuming ones, scoring systems available. But in clinical practice, what we can really score is the patient's functional assessment. Now, for major surgeries like lung resection and all, the cardiopulmonary exercise testing is done, which is very important to predict the post-operative outcome. But this cardiopulmonary exercise testing, which require the sophisticated instruments, you require the resources. So why not to go for a simple patient functional assessment by the assessment of a metabolic equivalent of task, that is MET, where 1 MET is approximately the rate of oxygen consumption of 3.5 ml per kg per minute. So for a 70 kg man, 1 MET at rest, 1 MET is at a rest, okay, it is 3.5 ml into 70, that is 250 ml per minute approximately. So whenever they say that 2500 ml is the oxygen consumption, that corresponds to the 10 METs of a patient. So 4 METs is climbing the 2 flight of stairs. In during our PAC, what we ask that up 2 mala chढ़ सकते हो क्या 3 mala चढ़ सकते हो. So when the patient says that climbing 2 flight of stairs is okay, patient is 4 METs. If the patient says I'm swimming, I'm playing tennis, and he's doing heavy professional work, then he's having more than 10 METs. So that's the scoring. This is a Duke activity status score also used in cardiac surgeries. That also, gives the scores to according to the physical activity done. So if the patient says that he can climb up climb a flight of stairs, walk up a hill, then the score becomes 5.5. Also, there is a word in literature about the 6-minute walk test, which was given by American Thoracic Society, where we can, assess the patient's hemodynamics after the 6-minute walk test. But this also required a dedicated, person, the equipments and a proper place to carry out the 6-minute walk test. But yes, it's a simple test rather than going for the cardiopulmonary stress test. After functional status, we also should, by scoring, help us to give the different organ specific risk, like kidney injury risk assessment, as we have seen in the past lecture of AKI. What are the independent preoperative predictors for the postoperative ARF? That the studied factors are age, emergency surgery, associated liver disease, body mass index, high risk surgery, PVD, and COPD. So these are the risk factors, and this has been studied in various literature for assessment of the patient developing ARF in a previously normal renal function, which can go into the ARF. And they have also included the use of vasopressors used intraoperatively. How much was the dose? These are also the prediction. So there is a development of this acute kidney injury risk index patients going for the general surgery. There also they have parameters like age, male sex, active congestive heart failure, ascites, hypertension, emergency surgery, intraperitoneal surgery, and renal insufficiency. All these parameters have been graded. And as these risk factors are increasing, the risk of major complications are higher. For liver disease, there are the scoring system, as we all know in academics, Child-Pugh and a model of end-stage liver disease scoring, where the Child-Pugh considers bilirubin, albumin, INR, and encephalopathy and ascites of the patient. So there are 3 classes, A, B, C. C is more than 10 points, which is a severe liver disease or a severe cirrhosis. For the liver transplantation, we score the patient by this model of end-stage liver disease, which also considers the bilirubin, INR, serum creatinine. And there is a logistic regression of this, which gives us a score of whether the patient is fit for liver transplantation. And these are the extensively complicated one, but nowadays we have these apps available where we can just fill up the value and it gives us the score. ICU, I'm not going to talk about in detail, but if you have to go and do PAC in ICU, so I thought I'll just talk about the score, which is extensively used in ICU, is acute physiology and chronic health evaluation. There's an Apache score, which includes this acute physiological score, like what is patient's heart rate, BP, what is ABG, what are the investigations, and chronic health points also, like major health diseases, age. These are taken into consider, and it gives us a score. So this is the Apache 4 latest version, which is also available in the on the online paid version. We have to fill up these details like age, heart rate, respiratory rate, ABG values, creatinine, albumin. These values can be filled. Chronic health conditions like CRF, hepatic failure, leukemia, carcinoma can be filled, and it gives us the idea like the score is from 286. It gives us the idea how much is this patient score and what can be the estimated length of stay of patients. Like some patients might, relatives might ask that, doctor, kitna din ICU mein rakhna padega? How much, how many days, the patient should be in ICU. So we can just give this score, fill up the data and give the score, and, explain ourselves, give a justified reason that why we are doing so much, why we are asking these investigations for this particular patient. PONV prediction score. This is the recent European guidelines in the preoperative evaluation of adult going elective non-cardiac surgery, and we can see that introducing a PONV score is a level 1 evidence to prevent, have the reducing the incidence. A simple score like APFL score for a PONV prediction, like female gender or history of PONV, past history, motion sickness, non-smoker, post-operative opioid use, these can be graded, and we can have the, identify and score the patient who's high risk for PONV. Nowadays, more and more old people, the population, elderly population coming for a surgery. So I thought of mentioning about this frailty score, which is like from very fit to the terminally ill patient. This frailty scores is available on iPhone and Android smartphones via the acute frailty network. So this can also help us to have a stepwise approach. We can find out what is the frailty score, and we can discuss with the relatives of the patient. We have a shared decision making what kind of management is required for the old chap, like whether conservative treatment is appropriate or a surgery is required. So it can be helpful. All the scores we studied we saw were the mortality indexes. Now this is the Charlson comorbidity index, and this is the recent qualitative review I came across about the stratification tools. This is the one of the comorbidity index, highly studied, validated, which gives a score to all these clinical conditions like MI, congestive heart failure, dementia, cerebrovascular diseases. The moderate to severe liver disease has a 3 scores, and a malignancy, HIV/AIDS has a 6 score. So that's a high score. So that can predict the comorbidity. So all these frailty and comorbidity indexes have been found to be helpful in prediction of mortality and morbidity. This is the literature where the patients undergoing hip fractures and doing under regional anesthesia. These scores were really helpful to predict the mortality and morbidity. Risk score specific to pathology, when we say that this patients like hip fracture, there is something I came across about Nottingham's hip fracture score also. The orthopedicians will be helping. So these are the different score which also considers the parameters like age, sex, admission HB, what is the mental status, whether the patient is living in institution, what if it is a malignancy. So that is depending on the pathology also we can have the risk scores. The commonly used scores like that we use is obese patients. When come across, we are doing stop bang, that is snoring, tiredness, observe apnea, like somebody relative is observing that patient is having apnea during sleep, high blood pressure, body mass index more than 35 kg per meter square, age more than 50 years, neck circumference more than 40 centimeter, and male gender. So higher the score, more than 4, there'll be high risk in this obese patient. That's the stop bank score. That was the scoring. As we can see, there were patient specific scorings. Then there are, as we see that ASA also didn't include the surgery related or a care facility related scoring. So we should always consider what kind of surgery he is posted for. So surgery also has been divided into low risk, intermediate risk, and high risk. Like the high risk patient surgeries like aortic repair, non-carotid major vascular surgeries, emergency major procedures, and prolonged procedures with large fluid shift and blood loss are considered to be having the cardiac risk more than 5%. And the low risk surgeries are ophthalmological surgeries, minor head, neck biopsies, and prostate operations. There is this John Hopkins surgical criteria also. They have graded the surgeries as a minimally invasive, moderately invasive, and highly invasive, depending upon the blood loss. And American College of Cardiologists and American Heart Association has given this, depending upon the major cardiovascular event risk, the high risk surgery and the low risk. The endoscopy, cataract, and breast surgery are supposed to be the low risk surgeries to have less than 1% of the CV event. So depending on the surgeries also, we can use the different scores which we see that, like for general surgery, they have used POSSUM, P-POSSUM, that is Portsmouth variant of POSSUM, surgical outcome risk tool as we saw. Cardiac surgery, I think there is a separate talk will be there about the risk prediction in cardiac surgery. But just to know that for cardiac surgery, the commonly used score is Euro score. And again, heart valve surgery has an AMLR score, vascular surgery, V-POSSUM score. These are the validated scores used in literature. Organ-specific scoring system are, as we see, the cardiac risk can be by RCRI, respiratory risk by RSCAT, kidney, general surgery, acute kidney injury index classification, and for liver, we can have CTP or MELD score. Anesthesia PAC will not be complete without an airway assessment. So first of all, I would like to, whenever you have to assess the airway, first you do self-assessment, whether I'll be able to intubate this patient, whether I'll be able to put LMA to this patient. And then we have some group indices like Wilson score, Arne's risk index, and Lemon assessment. The Wilson score, as we all know, it includes weight of the patient, head neck movement of the patient, jaw movement, receding mandible, and buck teeth. So if the score is more than 8 to 10, it's severe difficulty in laryngoscopy. Arne's risk index also includes the history of difficult intubation, past history of difficult intubation. Is there any pathologies associated with difficult intubation, clinical symptoms of airway pathology, thyromental distance, head neck movement, MPC, mouth opening, and jaw protrusion. So these different score of more than 11 gives us the difficult prediction as a difficult airway. So this RNA's risk index has to be found to have the maximum positive predictive value amongst all the different kind of airway assessment tools available. I would like to just go back to our basics and revise about the Lemon law. There's a Lemon score, which we should be knowing in the airway assessment, that is looking for the facial trauma, large incisors, beard, large tongue, evaluating to 3-3-2, that is inter-incisors distance, 3 fingers, hyomental distance, 3 fingers, and thyroid to floor, mouth, 2 fingers, MPC, and obstruction, and neck movement. That's the Lemon law we have to follow in every patient. MPC, again, scoring which is extensively used, and 3-3-2, finding out the mouth opening, hyomental distance, and angle of floor of mouth to the thyroid distance. That is 3-3-2 rule can be used. Prediction for the difficult bag-wall mask ventilation, we can just remember some of these mnemonics for airway assessment and scoring. The bag-wall mask ventilation, and we know that the difficult mask seal difficulty, M, O for obesity, A for age more than 55, N for no teeth, edentulous patient can have bag-wall mask ventilation difficult. S is sleep apnea and stiff lungs, or the stiff chest patient can have difficult bag-wall mask ventilation. Difficult SGD, that is supraglottic airway devices, can be rods, where R is restriction, O is obstruction, obesity, D is distorted airway, and S is short neck or the thyromental distance. So rods you can remember for the difficult supraglottic airway devices, and short you can remember for difficult cricothyrotomy, that is surgery of other airway obstruction, hematoma, obesity, radiation distortion, and tumor. So shorts for the difficult cricothyrotomy. Word about the future, the use of artificial intelligence in pre-anesthesia checkup. We know that AI is coming into intraoperatively. Inside, we have a robots for intubation, we have a tele-anesthesia, then there is a closed-loop anesthesia delivery system. But it's really questionable where the clinical decision, what we make during our pre-anesthesia checkup can be replaced by AI. But there are some literature about this, logistic or the simple stepwise approaches used by AI, where just put a picture of a patient and these calculations are done by AI, and then will give us a score of whether this is patient of easy mask ventilation or easy intubation, or whether this patient is of difficult intubation. So there are some studies of using this creation of AI modules for intubation, where you just have to put the patient's picture, and by face images, the AI will give us the score about whether patient has predicted to have a difficult intubation or ventilation. The limitations of all this preoperative scoring system, as we see, there are different apps and online models are available for putting the data, and we can have the score. Though clinically we are not, there is no personal experience. I am not used any of these scores. but the literature shows that the people are using, but there isn't a single universal scoring system for categorizing the patients in a pre-anesthesia. So the commonly methods we can say is the ASA physical status classification, MPC grade. For risk scoring, we can have Lee's RCRI index and holistic approach, which is tailored to each patient, depending upon the patient's medical history, his clinical current status, and any what kind of surgery he's planned for. We can use the different scorings. So the scores which can be helpful for us for identification of adverse perioperative events, so that we can take some targeted intervention, like we can optimize the patient, we can assess and discuss the fluid therapy of the patient, whether the patient requires a post-op respiratory or ICU support. We can explain this in our patient's consent, and we can have a shared decision making with our patients and clinicians. So that's the summary. Last word, it's like if the institutions and regions can develop their own scoring system depending upon the patient demographic, but the focus is not merely on having a score, but focus should be on optimizing the patient care and minimizing the risk. And always there should be open communication between patient, surgeon, and anesthetist. That's a very crucial approach in any pre-anesthetic process, and having a score. Lastly, I'll conclude with the question again, so that I will understand whether I'm able to put forward my points. So the oxygen consumption is measured in 70 kg man on a treadmill is giving is 2500 ml per minute. In treadmill it is giving his oxygen consumption is 2500 ml per minute. So the patient scores will be 1 met, 5 met, or 10 mets, or 15 mets. So people can answer in chat box. Correct. So as we know, the 1 met, which is at resting, 1 met at resting is 3.5 ml per kg per minute is oxygen consumption. This patient is having 2500 ml, 70 kg. So he's really having a good med, that is 10 meds. That's the correct answer. Thank you.
Thank you, madam. Thank you for an excellent eye-opener presentation for all of us. Not many people may be aware of so many scoring systems that are available.
Yeah.
Yeah, but as you correctly concluded that you have to choose one of the easiest system for you in the day-to-day practical approach in your private practice.
Yes.
And then tailor-made approach for each individual person.
Yes.
In their own institutions.
Yes.
And go ahead. Thank you so much. Are there any questions, Dr. Garud, for madam in the chat box?
No, madam. Thank you. There are no questions.
Thank you. Thank you so much.
Okay, so we'll proceed with our next topic. I invite Dr. Agam Bora sir. Has Dr. Agam sir joined? Agam Bora sir, are you there?
Yes.
Yeah, welcome, sir. Agam Bora sir is going to enlighten us on basics of PFT and advances in PFT as a tool for assessing our patients in the PAC. Agam Bora sir is a honorary chest physician at Karuna Hospital and Suchek Hospital. He was in charge of chest and TB department at Cooper Hospital from 2002 to 2019. He is currently Secretary General of Association of Physical Physicians of India. He is a trustee of Malad Medical Association and President of Geriatric Society of India, and many posts to his credit. He has many publications and awards. Over to you, sir, for the topic.
Good evening, everybody, and thank you, Samir bhai, for those nice words of introduction. And after those very difficult talks on various scorings and thyroid, I bring you to one very simple topic, and that is spirometry for anesthetist. At the outset, I must express my sincere thanks to my teacher, Professor Director Dr. K.C. Mohanty, not only taught me respiratory medicine, but also made me worth be here in front of you on this stage. Of course, the next best sincere thanks to the one who holds the true power of tranquility, both in the operation theater and in my bedroom. The incredible, only, one and only, as I say, Bijal. She not only knows the art of inducing sleep in patients, but also is perfected. She's mastered the unique skill of knocking her chest physician husband into the world of dreams. So thank you, Bijal, for that. Of course, the whole team, ISA, Dr. Rao, Dr. Shilpa, Samir Bhai, all my co-speakers for doing this fantastic job. All of you for logging in on this platform, and I'm told that you are there for more than 2.5 to 3 years. Education partners, and today also happens to be a very important day for me, and that's Physicians' Day. So I bring you Physicians' Day greetings to you. This is actually, I would say that Physicians' Day celebration, because API, the Association of Physicians of India, who's currently I'm the secretary, is completing 79 years today. So few like-minded people gathered somewhere around way back in 1944 and realized the need for having a platform. And this platform has grown by leaps and bounds. And today we are more than 22,000 members across the length and breadth of our country. And what can be a better way to celebrate Physicians' Day than to have a gathering like this, a meeting like this, which would help enhance our knowledge, which would help us in treating our patients better. After all, we physicians get pleasure only when we see our patients smiling. As I was talking to Bijal the other day, it's not now the Rose Day or the Valentine Day or the Teddy Bear Day excites me as much as the World COPD Day or World Tuberculosis Day or World Anesthesia Day for that matter, or the Physicians Day for that matter. And I'm so happy that we are celebrating it together. I must thank all of you for joining in today. It reflects your commitment to the subject, commitment to your patients, to your society. And next 15-20 minutes, I'm going to focus on lung function test, the indications of spirometry, the various loops and graphs and those curves that you see on the report, which is brought to you, a quick interpretation and some sample charts. So when I talk about pulmonary function testing, what do I mean by pulmonary function? It is actually the assessment of integrated performance of your cardiorespiratory system. So it's never isolated lung function. For testing individual component of this apparatus, for sorting out the function of individual elements in the complex interplay which results into gas exchange. The whole idea of doing lung function is to understand how is this gas exchange happening. And we very routinely do spirometry, but trust me, pulmonary function test would include hell lot of tests. If you are looking at tests for ventilations, you have spirometry with this helium dilution, you have body plethysmography. When you're looking at functions of diffusion, you have DLCO test. When you're looking at the ventilation perfusion test, it is called VQ scan, or there is something called as nitrogen washout test. There are special tests available which is called excise testing. You all are very well aware that arterial blood gases, resting arterial blood gases, can give you very good idea about lung functions. There could be certain bedside tests. Many a times your patients cannot get them. Many a times your patients cannot be brought to pulmonary function test laboratories, and you can do certain tests like peak expiratory flow. You may have CO2 monitoring, or what you do is ETCO2 monitoring. You may even do oxygen saturation, pulse oximetry monitoring. There are certain tests for respiratory muscle function, which could be PI max and PE max, that is inspiratory and expiratory max. There are tests for respiratory function, and that could be CO2 stimulation test. And there are some tests which are for sleep-related respiratory disorders, and that is polysomnography. So when I say pulmonary function test, this is the whole list of tests which could give you idea about pulmonary function. But trust me, Spirometry is the most basic and most widely used method for evaluating pulmonary function. And for all practical purposes, for your preoperative, perioperative evaluation, spirometry coupled with clinical examination, coupled with, if required, arterial blood gases would give you a fairly decent idea. Spirometry is a measure of airflow during inspiration and expiration, and it can be very well performed in your consulting room. And it has got very simple and affordable equipment called spirometer. So the concept of lung function testing is not new. It is old. About 350 years, we knew that there is a volume of air which a man can inhale during single breath. And the evaluation or the calculation of the concept started way back in 1679. For a quick revision, when we do lung function, we look at 4 volumes and we look at 4 capacities. And capacities are combination of 2 volumes. So you look at tidal volume. Tidal volume is the air inspired and expired during normal quiet breathing. You have inspiratory reserve volume. It is the maximum amount of air which can be inhaled after a normal tidal inspiration. We have expiratory reserve volume, which is the maximum amount of air which can be exhaled from the resting expiratory level. And then you have a residual volume, which is the volume of air which would remain at the end of maximum expiration. So this much of air would remain in the lungs even after your maximum expiratory effort, and which is extremely important in maintaining homeostasis, your pH, your carbon dioxide levels. And then when it comes to volumes, volumes are combination of 2 capacities are a combination of 2 volumes. The volume of air that can be exhaled from lung after maximum inspiration is your vital capacity, and it can be measured as forced vital capacity when done forcefully, or slow vital capacity when done relatively slowly. And it is the combination of inspiratory reserve tidal volume and expiratory reserve volume. Inspiratory capacity, it is the maximum amount of air which can be inhaled from a tidal breathing. So it is a sum total of inspiratory reserve volume and a tidal volume. And then is the FRC. It is the amount of air which will remain in the lung at the end of your tidal breathing, which is the total of expiratory reserve volume and residual volume. And then is the total lung capacity, which is the total of IRV, inspiratory reserve volume, tidal volume, expiratory reserve volume, and the residual volume. So the first spirometer was designed way back in 1846, and I'm sure everybody here during your physiology classes remember this spirometer, which was a water seal spirometer. You would blow out at one end, there would be a rotating drum which is kept on a water container, and with the movement of air, water will be dispersed. It would lead to rotation of that particular chamber inside, and there'll be a pointer there which would move depending on the amount of volume displaced and will give you a graph. That was the first spirometer that I had my experience with during my first year of physiology classes. But today times have changed, and we've got fantastic spirometers. You've got wedge bellows, you've got pneumatograph, you've got digital turbine, you've got thermistors, Foster device, mass flow sensor devices, and they work on the principle of differential pressures or the turbulences, the flow sensing, etc. And they're very, very simple. So apart from your perioperative risk analysis, spirometry is also useful for understanding 2 basic disorders of lung, and that is obstructive airway and restrictive airway. As I always tell my students, anything that starts from nose till the respiratory airways is obstructive. And anything that happens in pulmonary, parenchymal, outside leads to restrictive lung. So you have a case of lung fibrosis, pleural effusion, pleural thickening, muscle disorders, paralysis, stroke, cerebrovascular accident, everything will be a restrictive pattern. And anything starting from nose to the airways, your asthma, your COPD, your pressure on the airways would give you obstructive pattern. When you analyze spirometry, look at it is a effort dependent test. It's not like your 2D echo where it would depend on the sensitivity of that machine and expertise of that doctor doing 2D echo. Here, it also depends on anxiety and apprehension of this patient, the treatment that is on, the pain and fatigue if he's got, and the smoking if is actively on. There would be certain other factors like standardization. So you will have to put the normal values. So what kind of normal charts you accept, whether it is going to be a Caucasian, Indian. So there are various reference values available. Depending on what you choose, your spirometric calculation may change. We may have to look at the equipment sensitivity, motivation of a technician, because it's only his motivation that would decide the correct way. If he's not motivated enough, if patient does not perform well, you will get a fallacious report. And I've got patients reports who have asthma, who've got documented obstructive airway disease, have a complete restrictive pattern on PFT, and patients of interstitial lung disease who are supposed to have a restrictive defect will produce an obstructive pattern. One must have adequate attempts before you conclude that PFT, and there should not be much of variability. One has to look at dead space, the breath holding, hemoglobin of blood, at what altitude you're doing, height, weight, age. So these are various analytic factors you would consider before interpreting a spirometry. It must be done in a sitting position, and one must have 3 efforts minimum. There should not be much variation. There has to be only 5% variation in these 3 reports. If there is much variation, probably that's not the standard PFT and you may not be able to interpret it properly. There has to be a 6 seconds of minimum expiratory time. It must be done in sitting position with smooth effort, and there must not be any cough. If you are looking at the plateau between inspiration and expiration, there has to be about 2 seconds plateau. That would make it the ideal spirometry. Spirometry recordings are in 2 forms. So you have absolute values there and a graph. And graphs give you quick information. So you have 2 graphs. One graph is volume versus time, and second is flow rate versus volume. So this is that first graph, which is volume versus time. And second is the flow rate versus volume. So you have a down part, which is inspiration, and the top part, which is expiration. So you have and these are the different values. So you have FEF 25, you have FEF 50, your forced expiratory flow at 75%, peak flow reading. So various different readings that you see in spirometry are here, but all you have to do is look at only 3 or 4 values, which will help you interpret spirometry in no time. It is only a diagnostic aid and should be interpreted with clinical and radiological correlation. So please don't look at spirometry alone. I also tell this to chest physician colleagues and physician friends. Don't look at spirometry alone. Have a clinical evaluation first. Look at the radiological correlation and then only look at spirometry. It will give you 2 basic patterns. One is obstructive and second one is restrictive. These are various disorders that would have airflow obstruction or obstructive pattern. It's COPD, asthma. It could be obliterative bronchiolitis. It would be bronchitis that you see during the seasons when patients cough. It is not advisable to do spirometry when there is active cough going on, but if you do it during this kind of irritating cough or so-called as COVID episode which are going, or the RSV infection that we feel is prevalent in community now, you may get obstructive pattern. Look at 2 values. Look at FeV1 by FVC first, and then look at FeV1 value. Whenever your FeV1 by FVC is less than 70%, it confirms obstruction. And then look at FeV1. If FeV1 is 60 to 80%, it is mild. If FeV1 is 40 to 60, it is moderate. And if it is less than 40, it is severe obstruction. So this is what you will see in this both loop. You have, since the lungs are normal, it is mainly an airway disease. Patient will eventually blow out entire air, but it would take time. So if you look at the top graph, a normal value would be a straight line, and a dotted line shows that eventually entire air goes out, but it takes longer time. So at the end of first second, there is far lesser volume which is exhaled compared to what would have happened normally. And if you look at the second curve, you look at the expiratory curve, we know that during asthma, expiration is a problem. You see this coving happening, this kind of coving, but there is complete exhalation. This is a obstructive pattern. You may give salbutamol inhaler and repeat the spirometry. If there is improvement in spirometry by about 12% or 200 ml, it is called reversible, and that would mean it is asthma. If it is irreversible, it is called COPD. Then you look at restrictive disease. You look at FeV1 by FVC. It has to be more than 70%. Then you look at FVC values. If FVC values are 60 to 80, 50 to 60 and less than 50, it is accordingly mild, moderate, and severe restriction. So if you see restrictive disorder or normal is this particular line, a restrictive will be lower. The patient has a far smaller lungs, and hence the capacity is going to be smaller. The patient will not be able to exhale what otherwise would have happened. So there will be far lesser amount of air which is exhaled, but at the end of FEV1 there will be less air, and at the end of completion of 6 seconds there will be far lesser air which would be brought out from their lungs. So look at the first graph, the normal would have been the straight line and the dotted line shows reduced. And when you look at the flow volume curve, it shows tall and narrow graph where there is far less amount of air in the lung. So what are the diseases which are associated with restrictive defect? We could have pulmonary fibrosis, occupational lung, pulmonary edema, parenchymal lung tumors, a surgical lung where part of the lung is removed. Extrapulmonary, it could be thoracic cage deformity, obesity, pregnancy, fibrothorax, etc. And then you may have mixed pattern also where there may be overlapping features. So this is a simple slide that looks very busy, will help you arrive at a diagnosis by just looking at 2 or 3 values. So look at FEV1 by FVC first. If FEV1 by FVC is normal, you look at FVC next. If FVC is normal, you're talking about a normal spirometry. If FVC is reduced, you're talking about restriction. And then look at the percentage, 60 to 80, 40 to 60, less than 40, and you label them as mild, moderate, or severe restriction. If your FEV1 by FVC is reduced, you're talking about obstructive airway disease. And with that, if FVC is normal, it is a purely obstructive disease. If both FEV1 by FVC and FVC both are reduced, you're talking about a mixed disorder. You have this kind of chart freely available online. You could download it, put those values which you see on your graph, and it will quickly tell you whether it is a normal spirometry, restrictive defect, obstructive defect, or a mixed disorder. There could be multiple errors in the test or in the measurement. There could be leak around the mouthpiece. There could be inadequate effort. There could be glottic closure. There could be tongue fall. There could be cough in between. It could be poor coordination. It could be issue with obstruction. Patient may have obstruction with the mouthpiece. Patient may have faulty denture and may not be able to hold mouthpiece in between the tongue and the teeth. And this could lead to fallacious results. So when you look at this graph, the first one is a good effort. Second one, as you can see, there is variability in the effort, which would be sub-maximal effort, and various pattern would tell you whether patient is cough in between, patient had a poor start, or patient did not blow completely. There could be glottic closure. This also volume loop may give you the same information. There could be cough, there could be suboptimal inspiration, there could be suboptimal expiration, there could be tongue fall in between, there could be occlusion of vocal cords, which will give you faulty results. There are no absolute contraindications to do PFT, but yes, obviously during acute infections, you will not do it. During hemoptysis, you will not do it. If there is a pneumothorax, if there is any hemodynamic instability, one would not do PFT. And for perioperative analysis, if patient is bedridden, by and large, PFT may not give you right values. All those bedridden patients, all those patients who are in pain, your orthopedic cases, you may not be able to do spirometry. And yes, PFT can also lead to complications. PFT can induce syncope. It can give you pneumothorax. It can give you coughing. It can lead to bronchospasm. And there could be transfer of infection. And there are various infection measure controls available. In fact, there are disposable mouthpiece available. There are mouthpiece with filters available, which could reduce the cross infection or the transfer of infection from one patient to the other. And I will give you some sample PFT charts before I wind up. And this is the case of sclerosis. This sclerosis patient will have pulmonary involvement in terms of interstitial lung disease. So this is actually a case of ILD. ILD, one would expect a restrictive disorder. Look at first, the one that is marked in orange, FEV1 by FVC value. You see that is 90% before, and in the second column, it is 96%. There is 6%, which is hardly any change. Look at FVC value. FVC value is 52%. And when you give bronchodilator, look at the after value, which is 53%. There is no improvement. That means FeV1 by FVC is normal. It is not less than 0.7 or 70%. You're talking about a restrictive disease. Look at FVC is 50. That means you're talking about a moderate restriction. And there is no improvement after bronchodilator, which is as expected. You will see improvement only in obstructive lung disease. And here I present a case of obstructive airway disease. So you have a case of bronchial asthma. Look at FeV1 by FVC. It is 50%. You look at the after values, it shows 67.4%. Look at FeV1 value, the one in black. It shows 34% rise or 300 ml improvement. And hence, it is purely an obstructive airway disease. It is a severe obstructive airway disease with a very good reversibility. Post bronchodilator would be the interpretation. And one more PFT report. Look at FeV1 by FVC 60% pre, 60% post. FVC 50%, 50%. This is actually a case of obstructive airway disease without any improvement post bronchodilator. And there is even a restrictive component. Very likely this patient has a COPD with lot of protein energy malnutrition leading to muscle wasting. I would conclude by saying that spirometry is not a difficult test. Do ask for more and more spirometry. It is useful tool not only to detect various diseases, monitor various diseases. You cannot diagnose unless you diagnose. You cannot, decide the treatment plan, and you cannot monitor progress of this disease. You may miss a lot of cases of COPD otherwise if you don't ask for spirometry. And when it comes to perioperative analysis, I think if your FVC values are more than 1.2, there is not going to be CO2 retention. So this patient will not be into type 2 respiratory failure. And to my mind, if patient is able to walk well, to my mind, if patient is able to climb 2 flights of stairs, his spirometry is by and large adequate for him to undergo a major surgery. I would end by saying that to my mind, anesthesia is far more complicated. To my mind, you must put all your resources in managing anesthesia part of it, and the pulmonary fitness should be left to poor chest physicians like me. Thank you very much for your patient hearing.
Thank you, sir. Thank you so much for a nice and elaborate presentation. And we'll be definitely sending our patients to you for PFT workups. Any questions, Dr. Garud sir, in the chat box?
Yeah, there is one question, Dr. Agam.
Sir.
Any specific investigations in ILD for risk assessment and implications to be considered for GA?
By and large, I would ask for 2 investigations. One is the spirometry. If patient cannot perform spirometry, please do all those bedside tests. As I told you, if patient is able to walk or not walk, or you can actually keep, what you call a candle at about 6 feet distance and ask him to blow. Make it at 5 feet, make it at 4 feet, and look at the effort it takes to blow that. If he's able to blow at 6 feet, probably done. He's fit for any surgery. Now, if you're not able to do this, then next test would be blood gas tests. I think it is very easy and available routinely now at least the places where you and me work. One blood gases, and if there is no resting hypoxia, I think I'm fine to give fitness to this patient. Thank you.
Thank you, Dr. Agam.
Thank you, sir. I thoroughly enjoyed being with anesthesia, especially when Bijal is locked in. Bijal always wondered what I do in the evenings in this program. So thank Bijal for being there. Hope you're there. Oh, can't see her. Anyway, thank you.
Hello, sir.
Shilpa.
Hello, yeah. I'm there, very much there. Very nice talk. Actually, we had a interesting discussion for this. I feel that whether with nowadays we ask more of ABG compared to PFT.
Absolutely. It's very convenient.
PFT जो कुछ होगा हम तो manage कर लेंगे हमारे ventilator पे. Like we adjust our ventilator setting, we have advanced settings. So, but you concluded saying that we should go for more PFTs.
No, it's not about, I think I could not give the right message. It's not about managing during surgery. It is always problem after surgery. So I'm sure during surgery, you have fantastic tools available, but you can imagine if you have not picked up a sleep apnea in this patient would be hooked on the ICU with this non-invasive ventilator for 2 days. This patient may require a tube in for a longer time. Patient have all those ventilator and ventilator associated complication in the perioperative period. So it is mainly for better understanding of perioperative care, because during surgery, so you are experts there. I'm just trying to reduce my problems. When you shift this patient from your OT to my ICU, and then I'm gone. Thank you.
Yeah, thank you so much, sir.
Thank you. Bye-bye.
Bye.
It's time to move on to our next topic, the final topic. I invite Dr. Priyamvada Deshmukh for a journal review. Madam is a consultant anesthesiologist at Sarthak Maternity. She has done MD from Nair Hospital and with 2 years experience at Tata Hospitals in onco anesthesia. Her main areas of interest is obstetric anesthesia, labor analgesia, airway management, and ACLS. She has been a faculty at 2nd and 3rd UA Mahakon. Welcome, ma'am, and over to you for your topic.
Thank you, sir. So as we are coming to the end of this webinar, we are actually reaching our safety finish line. We have a lot of insights from all esteemed speakers. So let's quickly go through a journal review or journal read. It is pride for each one of us because we are going to discuss about preoperative investigations. These are the practice guidelines given by the Indian Society of Anesthesiology, which was published in the Indian Journal of Anesthesia on 19th May 2022. So as we all know, preoperative investigations are essential for planning, stratification, optimization, and perioperative management of our patients. So the ultimate aim is to improve patient outcome. There is no uniformity in the previously published guidelines from various professional bodies across the globe due to the changes in the socioeconomic, demographic, and medico-legal factors. So the practices prevalent in the Indian subcontinent are ordering very minimal investigations to a battery of investigations. Now with the presence of auto-analyzers, the trend is ordering a battery of investigations for each and every procedure. So what was the focus of this guidelines? The focus of this guidelines was to provide recommendations for routine preoperative investigations for ASA 1 and 2 patients for elective surgeries, which may influence our perioperative anesthetic management and the outcome of the patients. They also give us an idea about VT PIN, which is the validity time for previous investigations. So if an investigation is done 1 month prior, should we repeat the investigation or we are okay with it? So the methodology which was followed was there was a core committee which consisted of our president, our secretary, and 7 members, and a group of expert committee with 17 plus members with great academic standing across India. So the literature search was conducted from 1st Jan 2010 to 25th November 2021, and a 3-step Delphi methodology was followed to arrive at the consensus on these recommendations. So very quickly, what is this 3-step methodologies? There were questions and recommendations prepared by the core committee, and they were given via a Google survey form to the expert group, and they were requested to accept, reject, or review the recommendations. And there was a second round for unresolved draft recommendations, and finally there was a virtual meeting and with the core committee and the expert committee, and a consensus was reached. So before going to the guidelines, they divided the surgeries in minor, intermediate, and major surgeries, depending on the invasiveness of the surgery and the duration of the procedure. And what was studied is whether that investigation and that particular surgery, what was the impact on the patient? For example, the minor impacts were whether there was any delay in the procedure, whether there were any extra referrals advised, or whether there were any further investigations asked for. And the major impact which was studied was whether there was any postponement of surgery, whether there was any change in the management plan or anesthetic intervention, or whether there was any change in the monitoring plan. All this was taken into account, and these are the recommendations or the guidelines. So recommendation 1 is CBC is done for all patients undergoing minor, intermediate, and major surgeries. Recommendation 2A and B, serum creatinine, which was taken as a marker for the renal function test, was not suggested for patients undergoing minor surgery, and 2B, serum creatinine was suggested for patients for intermediate and major surgeries. Again, as Amit sir said, serum creatinine, we need to know the baseline serum creatinine to know the trend. So recommendation 3, the serum electrolytes. Serum electrolytes were not suggested for patients undergoing minor, intermediate, and major surgeries. But again, it was individualization for that particular procedure, and that will be clear as we go through the later slides. Recommendation 4A, the liver function test. They were not suggested for patients undergoing minor and intermediate surgeries. Recommendation 4B, liver function test was suggested for patients undergoing major surgeries. Now, recommendation 5, the coagulation profile. The PT-INR and the APTT values, they were not suggested for patients undergoing minor, intermediate, and major surgery. Again, these are ASA 1 and 2 patients, and these are for elective surgery. Of course, they have mentioned that we need to follow the ASRA guidelines when we are planning for regional anesthesia or blocks for the procedure. Recommendation 6. In non-diabetic patients, blood sugar estimation is not suggested for patients scheduled for minor, intermediate, and major surgeries. Basically, what they say is a single value of blood sugar level was not making any impact on the outcome in the form of postponement of surgery or any presence of any infection post-operatively. That was what was studied in the literature search. Recommendation 7A, the non-cardiac patients, 12-lead ECG testing is suggested at age 45 years and above for minor and intermediate surgeries. And 7B, 12-lead ECG is suggested for all patients undergoing major surgeries. Recommendation 8, A and B, X-ray chest not for minor surgeries. X-ray chest for patients age more than 40, more than 50 is done for intermediate and major cases. The recommendation 9, the sonography of the airway is not suggested for predicting difficult airway. Again, it is an evolving field, and they need to know which parameters in the USG are more specific or sensitive. So right now, they are pressing on the scoring system, that is Malampatti scoring or the Mohs scoring, etc. Recommendation 10, that is the validity time for previously done investigations. So for CBC, renal function test, liver function test, and coag profile, the validity time is 2 months. So if the investigations are done 2 months prior, they're acceptable for an elective surgery, provided the clinical condition of the patient doesn't deteriorate during the time interval. And the VT-PIN or the validity time for X-ray and ECG is 12 months. So again, as we have seen in all the lectures, detailed history, physical examination, clinical evaluation, and the review of medications by the attending anesthesiologists may consider individualizing the decision on further investigation. So there is a very nice chart here, which we quickly revise the whole thing or summarize. So here they have given us the nature of surgery, minor, intermediate, and major, and the investigations are given. So the green color boxes are indicating that you should do those investigations, and the amber colored boxes say that you have to individualize those investigations depending on the patient. So simple minor cases go for CBC and 12-lead ECG if age more than 45 years. For intermediate surgeries, complete blood count, renal function test, 12-lead ECG for age more than 45, chest X-ray for age more than 50. And again, liver function test and coag profile blood sugar, you have to individualize. Major surgeries, yes, complete blood count, renal function test, liver function test, 12-lead ECG for all patients, and chest X-ray for patients age more than 50. And as we have already seen, the validity time for previously done investigations is 2 months for complete blood count, renal function test, and liver function test. And for ECG and chest X-ray, it is 12 months. So I would like to quote again Tasneem madam that here vigilance beyond guidelines is most important, and we have to display the latest guidelines in our OT. Thank you.
Thank you, madam, for an excellent presentation. Now I hand over the proceedings to Dr. Amola Parekh, madam, to conclude today's webinar. It was an excellent presentation by all the speakers and beautiful evening spent. Thank you, and over to you, Amola madam.
Yeah, thank you everybody. Today's all lectures were excellent. I thank all faculty members, Dr. Tasneem, Dr. Amit Jain, Dr. Shashank, Dr. Agam Vora, Dr. Pallavi, and Dr. Priyamveda. It was a really informative session, and I'm sure we are better equipped to manage our patients, to know when to wait and optimize, and when to if in case of emergency, how to manage those patients. I'm sure we are better informed after today's session. I also invite you all for 21st January in-person CME, which is going to be part 2 of this pre-anesthesia checkup. And it will be an in-person CME, a whole day CME, starting from 8 to 1, 2 o'clock in the afternoon. And I hope lots of you people can join and make it again. We will be coming up with topics of diabetes, hypertension, cardiac, neuro, and whatever we feel is left in the PAC. And we hope more and more of you can join us for the in-person CME. Thank you so much.
Madam, I have a small little suggestion to make, since now everybody is there on the forum right now. Now,
Yeah.
even Rajesh Rao sir, are you there, sir?
Yes, I am there.
Yeah. What I have seen is that we visit different nursing homes, different setups. There are different formats at every place for PACs and writing our operative notes. Can we have a standard format on behalf of BSA or ISA to be kept at each and every nursing and to be followed by each and every anesthetist practicing in our association, and to be kept at each and every nursing home, every place where we operate, so that there is a standardized protocol to write our PAC notes and the operative notes?
Yeah, I think
ISA has come out with, they have it on their website also. And wherever I go, most of the hospitals have given them those formats. You can download it from ISA web. It is available, and you can get it printed. It's already there.
But you want it to be on the name of ISA to be printed and kept at every place, or on with the name of BSA, like our
ISA
own?
provided, you can given that pro forma. It is properly, you can get it printed. If I can get it, I will just share a copy with you in the group.
So, do you intend that everybody of us should be following the same format to be kept everywhere and to be written?
Ideally, yes. It's precise.
Okay. Okay. Thank you. Thank you so much.
Many years ago, Neon had printed such forms and distributed among the anesthetists. And we are following those forms at many places.
But we also had bit printed by ISA Borivali.
Yeah, now we can get it printed by some of the pharma companies.
Yeah.
We had it with us. In fact, I've printed to quite a few nursing homes in my area. I got the paper, and now they are printing their own on the basis of that.
Yeah. But we do need some standard format. That's right.
The ISA format is pretty good, and I think we should all adopt that format and have a printout and keep them in all nursing homes.
Yes,
it is there on the ISA website.
Yes, it is also approved for NABH accreditation also. So those people also won't take objections to it. Otherwise, they interfere with the paperwork.
Okay then. Thank you, everyone.
Yeah.
Yeah.
Thank you, everyone,
Yeah,
for remaining logged in for almost more than 4 hours. It was really good, informative, and I'm sure we are better informed in managing our patients and optimizing them pre-op. Thank you, everybody.
Thank you, everyone.
Thank you.